Good morning. Calling this roundtable to order. Today is Monday, December 4th, 2023. The time is 10:01 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today, we are holding a joint roundtable with the Committee on Housing to hear from the public and our government agencies regarding enrollment for Health and Human Services and the DCAS system, better known as DCAS. The district has invested significant resources and time to develop a social safety net that should ensure all district residents are able to live healthily and with good quality of life. However, the district has encountered challenges when determining who is eligible to receive the health and human services that are supposed to support our residents. The Committee on Health has held two previous oversight roundtables on Medicaid renewals and redeterminations following the COVID-19 public health emergency. As of November 20th, 18,599 renewal applications are currently pending. Federal Medicaid regulations require these renewal applications be processed within 45 days. However, as of October, 43% of all pending renewals, more than 6,900 applications have been pending for longer than 60 days. 27% of all renewals, more than 4,300 applications had been pending for at least 90 days, or double the allowable timeframe. As of November, fully half of all pending renewals have been pending for at least 60 days. Similarly, after the pause in data reporting under SNAP during the COVID-19 public health emergency, the district has emerged as one of the worst performing programs with respect to timeliness in terms of processing SNAP applications. Just prior to COVID, the district performed in the top half of states with 93.84% of SNAP applications processed within the required timeframe. However, in fiscal year 2022, the reported application processing timeliness rate was just 42.86%. That is the lowest in the country by far. The next worst performer was Guam at 65.93%. While the district performed well for timeliness in fiscal year 2018 and 19, just prior to that, in 2017, the district had been toward the bottom of the timeliness performance rankings, coming in at number 46 in the country. Residents sued the district for its poor performance, yet that timeliness rate was 86.34%, more than double the 42.86% rate in FY22. There is a proposed settlement agreement for that lawsuit, which would require DHS to be more transparent with its quality and performance metrics. The district is also the worst performing state for the case and procedural error rate, with a fiscal year 22 error rate of 80.46%, the highest in the country. In correspondence from the U.S. Department of Agriculture, Food and Nutrition Service Agency, they largely blame this high error rate on issues with DCAS. Running in the background of all these challenges enrolling people in appropriate benefits is the exceedingly expensive software system that we call DCAS, which may be better known as by its public-facing name, District Direct. Since its inception in 2012 through fiscal year 2023, more than $600 million have been invested to develop DCAS. In FY24 alone, DCAS is budgeted to cost more than $97 million. Yet, even with these massive investments in the system, clearly something isn't working. The goals of DCAS project were laudable and are laudable. The system came out of the Affordable Care Act and was intended to create a streamlined, integrated, efficient single system to connect district residents with health and human service benefit options. Through the single portal, residents should be able to input their information once and have that data fed into the eligibility determination process for health and human service for district offers. Further, DCAS is supposed to collect information from existing databases like tax records to eliminate the need for residents to repeatedly enter the same data. However, federal requirements for data verification processes have limited the extent to which DCAS has been able to effectively streamline the application processes. The goal for this roundtable is to bring both agencies responsible for the benefits eligibility determination process together to try to better understand the barriers to timely processing. The Department of Healthcare Finance is responsible for the DCAS technology, and the Department of Human Services is responsible for the case managers who review the applications that come through the DCAS system to ultimately determine eligibility. We will first hear from public witnesses, and then we'll turn to our government agencies. But right now, I want to turn to my colleague, Councilmember Robert White, who chairs the Committee on Housing.
Thank you, Chairperson Henderson, for your sharp attention to this issue and for collaborating and co-hosting this important roundtable. One of the reasons it's important to have multiple agencies at the same hearing is so that no one can point to someone who isn't in the room and blame them for the issue. The problem we still have is that this is a process that started so many years ago. So we may have the issue of people pointing backwards, which is classic for government, but we're going to try to get around that. In 2013, the Department of Healthcare Finance, or DHCF, initiated the DCAS system, a program with a price tag of $600 million. The DC government promised residents an integrated eligibility system encompassing Medicaid, the Supplemental Nutrition Assistance Program, or SNAP, temporary assistance to needy families, or TANF, and additional programs like interim disability assistance, or IDA. On November 15th, 2021, the District Direct portal became public facing. This means residents exclusively use the District Direct website portal to apply for benefits, recertify, and submit changes in circumstances affecting their benefits. However, since its launch, the promise of efficiency and effectiveness has fallen short. The U.S. Department of Agriculture compiles nationwide statistics on the performance of administering agencies, including errors in denying, terminating, or suspending a household's SNAP benefits. In 2022, the district had the highest error rate in the country at 80.46%. DC has the slowest SNAP processing time in the country. Those errors and slowdowns impact real people waiting to meet their most basic needs. My committee found mistakes beyond SNAP, like in the case of two grandparents who adopted their grandchildren. They were wrongly taken off TANF benefits, and it took 3 months with my office's help to get their benefits back. Adding to these software and process issues, the mayor is increasing the harm by refusing to implement Give SNAP a raise, which the council funded. This means more than 140,000 residents won't get extra SNAP benefits that they expected. This speaks to a trend in this administration of not prioritizing the needs of our poorest residents. Just 2 weeks ago, through working with advocates, residents, and legal service providers, I had to stop the administration from taking $20.6 million out of the Emergency Rental Assistance Program. These actions are demonstrating a pattern. Under my committee, I have oversight over the Department of Human Services, which is responsible for processing applications entering the District Direct system. There seem to be errors by DHS, and there also appear to be various technological issues with District Direct that fall under the purview of DHCF. This hearing will help us get to the bottom of both. Before I end, I want to thank our legal service providers who have stepped in response to the numerous issues with District Direct. You have served as a critical line of defense for residents, actively supporting them, advocating on their behalf, and in hundreds of cases, working to get food on their tables, reinstate medical coverage, and secure necessary cash allotments. As we talk about complicated software and bureaucracy today, we have to remember that every error and delay is harming people, including our poorest families. Thank you again, Chairperson Henderson. I'm looking forward to hearing from our public witnesses and our government witnesses.
Thank you, Councilmember White. We will now call our first panel of witnesses, public witnesses. For those who haven't done a hybrid hearing with us in the past, you'll need to affirmatively accept our invitation to be promoted as a panelist. And then keep your mic on mute until it's your turn to speak. So we have 16 public witnesses, so we're just gonna split them 8 and 8. So Danita Moore, Tamika Taylor, Rebecca Steele, Will Doyle, Destiny Pelham, Allison Miles Lee, Padma Swami, and Catherine Posada. Give them a minute as they come in. Okay, I do not see Miss Moore. or Ms. Taylor, but I do see Rebecca Steele. So Rebecca, if you want to go ahead and get started. You're on mute, Rebecca.
Thank you. And good morning, council members White and Henderson. My name is Rebecca Steele. I'm a staff attorney at Legal Aid DC, and I appreciate the opportunity to discuss these important issues today. As you've already mentioned, DCAS creates significant barriers for district residents attempting to access the benefits that they are entitled to. The system is prone to errors at key junctures, including when residents apply, recertify, or report changes. And after a DCAS error is identified, it can take DHS weeks or months to fix it. The result is that residents are deprived of benefits, while DHS is often in violation of legal deadlines dictating when benefits are owed. The error and delay rates that you mentioned earlier are unacceptable, and in Legal Aid's experience are caused in large part by DCAS errors. Legal Aid regularly receives 10 to 15 applications for assistance per week related to DCAS errors. I would like to share just a few examples. DCAS often fails to increase benefits when a beneficiary reports a new household member. For example, anonymous Legal Aid client Ms. X promptly reported the birth of her child to DHS. Due to a DCAS error, her benefits were not increased to account for this new household member. The error was not fixed for 20 months, that she had to go without benefits she was owed that should have helped her in the urgent expenses associated with her newborn. Even after Ms. X sought a fair hearing and obtained an order setting a deadline for DHS to pay the benefits, DHS reported that they could not comply with the order due to issues with DCAS. DCAS errors also frequently arise at the initial application or recertification stage. For example, Ms. Y timely recertified for SNAP and TANF and later submitted accompanying documentation. A DCAS issue prevented her uploads from being processed. As a result, DCAS issued SNAP and TANF termination notices for failure to submit the exact documents that she uploaded more than a month earlier and that were not processed due to a DCAS issue. Despite Ms. Y calling the call center and filing a fair hearing request, her benefits were terminated. Even when her benefits were reinstated, DCAS calculated the wrong amount. The Office of Administrative Hearings ordered DHS to correct that amount, but DHS refused to comply by the deadline and again invoked DCAS as the reason for noncompliance. In addition to SNAP and TANF issues, Legal Aid has worked with clients whose Medicaid benefits have been seemingly randomly terminated as a result of DCAS errors. The Healthcare Ombudsman has stated that these terminations are a huge issue that they were receiving multiple calls about. In Legal Aid's experience, a DCAS error can frequently take months to correct. And even when the errors are corrected, impacted recipients are not made whole. By the time an error is corrected months later, it's too late to buy food on the nights that the family already went hungry. It's too late to reverse the serious health consequences of not having access to your doctor when you need them. It is particularly concerning that DHS withholds benefits even after acknowledging that they are owed and being ordered to release them by an administrative law judge. DHS frequently insists that benefits cannot be issued until the underlying DCAS error is addressed. By refusing to comply with statutes, regulations, and binding orders, DHS is effectively suggesting that DCAS is above the law. A multi-pronged approach is needed to address this DCAS crisis. First, DHS must improve the methods and tools available to prevent these DCAS issues from occurring in the first place. Whenever DCAS issues are brought to the agency's attention, DHS must evaluate whether it was a systemic error and address it not just for that individual, but across the board, if so. Second, DHS must improve the mechanisms in place to proactively identify and address errors. Wherever possible, the system should be programmed to flag cases that appear to present errors for staff review. For example, the system could flag when a recipient has uploaded information that has been pending for longer than the allotted processing period. Third, when a benefit recipient identifies an issue, there must be an effective way to bring that error to the agency's attention. For example, a separate phone line exclusively for DCAS errors. As it currently stands, recipients have no effective system to flag and resolve the DCAS issues that impact their cases. The call center and service centers are simply not equipped to resolve these issues. DHS must also develop an internal procedure to resolve reported DCAS issues and a strict timeline for doing so. This will likely require hiring more staff and introducing more training. Legal Aid also recommends the creation of a DCAS ombudsperson who would be available for recipients to contact with DCAS-specific issues and could facilitate their timely resolution. Fourth, and finally, where a DCAS problem cannot be fixed before benefits are due, DHS must implement a stopgap protocol that ensures benefits are issued on time. For example, a manual override after a certain period of time has elapsed. Thank you for the opportunity to discuss these important issues, and Legal Aid looks forward to the opportunity to work collaboratively towards resolving them. Thank you.
Thank you, Ms. Steele. Mr. Doyle? Will, you're on mute.
Sorry, didn't come off. Thank you. Thank you, Chairs Henderson and White, council members, and council staff. My name is Will Doyle, and I'm the Vice President of Housing First at Pathways to Housing DC. While the DCAS system has provided significant improvements for those needing the essential benefits administered by the ESA, we share concerns with software performance, slow processing times, applications not getting processed at all, and difficulty accessing staff when encountering issues in the application or recertification process. This feedback is grounded in the experience of our staff and over 800 clients served in our DC-based Housing First programs. The challenges I will share are being experienced despite our clients having support from staff. Additionally, the impact of these challenges on our clients is significant, as access to their medical insurance and food stamps is a crucial component of their success in housing and their recovery. Not requiring email addresses for creating DCAS accounts has been very helpful, as we work with a significant number of individuals who don't independently use them. However, simply trying to access DCAS can be a problem, as the system is frequently down. We have had several experiences of submitting applications for expedited food stamps and Medicaid with simply nothing done until we were able to reach someone by phone at the ESA. This consistently requires navigating long wait times and potentially repeated calls until you reach a staff member who can resolve the issue. However, even at that point, we have had situations in which the ESA staff member can't see the submitted application or recertification that is showing on our end in DCAS. While DCAS provides an easy means of uploading documents for submission, at times the document verification requests are non-specific and unclear. We have also had several experiences of uploading requested documents with no further processing of the Medicaid recertification. Recently, the vast majority of the activity we support clients with are Medicaid recertifications. However, the amount of information requested and time to complete is more appropriate for an initial application than a recertification. Even with our help, it regularly takes more than an hour to complete a Medicaid recertification. Although not related to the DCAS system, we have consistently witnessed an issue with Medicaid benefits not being reactivated when individuals are released from DC jail. Through contact with staff from the Office of Healthcare Ombudsman, I have directly been informed that the incarcerated status, or I code, should automatically be removed the night before release so that the individual can access medications and healthcare. This is not being done, and instead of the Office of Healthcare Ombudsman being able to get it resolved between the ESA and the Department of Corrections, the burden is being placed on the individual to submit proof of release. This denies and delays access to medications and healthcare at a crucial point of transition. Separately, the Office of Healthcare Ombudsman was typically not able to assist with other matters and simply reiterated communication they received from the ESA instead of offering solutions. To ensure that system and staffing issues do not compromise vulnerable residents' access to crucial benefits, I urge you to establish public timeframes for processing each unique application in DCAS with a direct point of contact for any applications that go beyond those timeframes. Establish a means for social service agencies to provide system feedback, ensure that incarcerated status is automatically removed the night before release, and finally, strengthen the role of the Office of Healthcare Ombudsman to provide support in reaching solutions. Thank you for holding this hearing. I'm happy to answer any questions.
Thank you, Mr. Doyle. I don't see Destiny, but I do see Allison. Allison?
Yes. Morning.
Good morning.
I'll take my 5 minutes as I'm talking on behalf of Bread for the City.
Okay. Go ahead.
Thanks. Good morning. My name's Allison Miles Lee. I'm a managing attorney at Bread for the City. I oversee our legal clinic's public benefits practice, where we represent clients who encounter issues with their DHS benefits through both informal resolution and litigation at the Office of Administrative Hearings. Bread for the City's care management team, located within our medical clinic, also helps our patients troubleshoot problems with their DHS benefits programs and has extensive experience navigating DCAS. Members of our legal and medical clinics have been testifying about DHS before this council for many years. 2 years ago, when DHS and DHCF rolled out the new District Direct portal, since that time, Bread for the City and other advocates have repeatedly sounded alarms about system breakdowns. These problems with District Direct and DHS operations have been well documented. I thank Council members Robert White Jr. and Christina Henderson for convening this roundtable. I appreciate the opportunity to attend along with DHS and DHCF. I hope that we can have a candid discussion about what supports the agencies need from the council to remedy existing problems and how advocates can help people better navigate these systems. Earlier this year, advocates met with Councilmember White's office and representatives from DHS to start this conversation. Following that meeting, we sent a list of questions to DHS through Councilmember White. I'd like to focus today on a few of DHS's responses about fixing technical problems and OAH fair hearings. These are two main areas where legal services attorneys still feel that matters are unresolved. You can read my written testimony for more information. First, advocates asked for information about how DHS is addressing specific technical issues that customers encounter with District Direct. DHS just responded that, quote, DCAS team provides system updates to fix outstanding issues or to enhance functionality. And the agency pointed out examples of parts of the system that do work and that we had not raised as concerns. We were disappointed in this response as we were hoping to hear that DHS had a plan in place, including a timeline, to resolve specific technical issues with District Direct that customers and advocates have repeatedly reported. These ongoing issues include difficulty changing passwords, getting stuck with tech glitches in the process of completing an application online, and encountering numerous requests for verification that make no sense. Like Alliance applicants who get 5 or 6 requests for verification of SSN when they do not even claim to have a social security number, or SNAP applicants who are asked for verification of medical insurance. Advocates also asked DHS who is responsible for creating District Direct and resolving issues with the portal. DHS responded that it is DHCF that is, quote, fully responsible for oversight and management. Our understanding is that DHS has an obligation as a state agency responsible for determining eligibility and administering federal public benefits. This responsibility cannot be totally shifted onto DHCF, even if that agency may control DCAS. Finally, advocates asked DHS what the agency is doing to comply with OAH orders. The response was, DHS has corrected the customer's public assistance benefits in all cases in which it has determined that the benefits were incorrect or in which OAH has ordered the agency to do so. This is true eventually, but it should not take filing a fair hearing request, attending an administrative review conference, and appearing in front of an OAH judge before DHS provides undisputed benefits owed to a customer. In a number of our cases, OAH judges have sanctioned DHS for the long time it's taken for the agency to provide these undisputed benefits. In some cases, the agency has been fined yet again for failure to timely pay the original sanction. This approach to resolving client matters is a terrible waste of time and resources for customers, the agency, advocates, and OAH judges whose calendars are already full of matters that are actually in dispute. It's critical that DHS and to some extent DHCF improve DCAS and the in-person infrastructure to support customers who cannot navigate the system on their own. As things stand now, we have nowhere to send people who are struggling. Organizations like Bread for the City are available to help clients with problems at DHS, but we are constantly at capacity. Our legal clinic staff would be better used helping people with substantive disagreements at DHS rather than these system glitches and processing problems. Likewise, well-meaning and very competent DHS staff in high-level administrative, hearing review, and policy analyst positions are spending far too much time dealing with issues that should be easily resolved. The system cannot continue as is, and we look forward to working with the agency towards solutions. Thank you.
Thank you. Dr. Swami?
Hi, can y'all hear me?
Yes.
Good morning, Chairpersons Henderson, White, and the committee and the members of the committees of Health and Housing. My name is Padma Swami, and I'm the Associate Medical Director at the Children's National, the ARC and Mobile Clinic Program, and an Assistant Professor of Pediatrics at George Washington University School of Medicine and Health Sciences. Children's National is an integral part of the fabric of this region, serving the nation's children and families for over 150 years. Thank you for this opportunity to provide testimony at this joint roundtable. The COVID-19 pandemic has impacted multiple facets of everyday life, including significant economic impacts that have resulted in increased poverty. According to Georgetown's Center for Families, Medicaid enrollment increased by 28% nationally from February 2020 to August 2022. Now that we are entering the post-pandemic recovery period, the pandemic protections of Medicaid, which safeguarded children, are slowly being unwound. The Kaiser Family Foundation has a Medicaid unwinding tracker by state. And according to the tracker, about 1 in 4, or 25,000 people, have had their Medicaid terminated due to procedural reasons. This in turn affects if someone is able to access care. Working with a primarily Medicaid population, I see the impacts of how access to care impacts overall general health. In particular, COVID-19 resulted in decreased access to healthcare impacting child health. Some of the acute health issues that arose include pediatric mental health and delayed recognition of pediatric developmental delays. A systematic review looked at 65,000 kids and found that about 28% had anxiety and 23% had depression during the pandemic period. And this mirrors the reality of what I see in clinic. Limited access to care resulted in decreased identification of developmental concerns. And due to this, families with developmental concerns are having to wait at least 6 to 12 months to get seen by developmental specialists. I worry that disenrollment from Medicaid due to procedural reasons could further cause delays in treatment of mental health conditions and recognition of developmental conditions that benefit from early treatment. According to the WHO, the social determinants of health are the conditions in which we grow, live, and thrive. As we increasingly digitize access to services, internet access is a key social determinant of health. The pandemic highlighted the digital divide, and for many families, internet access is via the phone. Some of the families I serve are often working paycheck to paycheck. I had one mother share with me during a visit that she had a choice of either buying food or paying for the cell phone bill. For many of the families I serve, the cell phone is the source of internet, which is how they stay enrolled and connected to services. I worry that with connectivity issues, that families' access to services could be impacted. How can we keep children connected to Medicaid so that their growth and development can be monitored? Continuous Medicaid coverage is key to ensuring that low-income children are covered. One benefit of continuous Medicaid coverage is decreased administrative costs due to the churn and families needing to enroll. Another benefit is with increased access to preventative care, there is decreased utilization of high-cost services like hospitalization. A study published in Medical Care showed that in California, after implementation of continuous coverage of Medicaid for children, that there was a $17 million decrease in hospital-related costs. While financial benefits is one piece, I work with individual children and families, and ensuring coverage is one step towards improving access to care. And this in turn means that I can see children and connect them to services earlier so they can thrive and grow. My role as a pediatrician is to help our children become healthy adults, and policies like continuous Medicaid coverage make my job easier. Thank you for the opportunity to provide testimony, and I'm happy to answer any questions you may have.
Thank you. Dr. Posada?
Good morning.
Good morning.
Chairwoman Henderson, Chairman White, members of the committee and staff, thank you for the opportunity to provide testimony today. My name is Dr. Catherine Posada, and I am a pediatrician with the Complex Care Program at Children's National Hospital. Children's National is an integral part of the fabric of this region, serving Washington, D.C.'s children and families for over 150 years. Thank you for the opportunity to provide testimony on the discussion of health and human benefits enrollment and the DC access system. In my role at Children's National, I am a pediatrician who provides primary care to children with medical complexities within the Complex Care Program. The Complex Care Program is a primary care medical home for children with medical complexities to be able to access comprehensive medical care, receive care coordination, and assist with the continuity of care this vulnerable patient population deserve. When we speak with families who face a lapse in Medicaid coverage, we witness firsthand the heavy burden faced by our patients and their families and know that this can potentially be life-threatening. The patients I care for have a wide range of medical needs that are directly linked to their insurance coverage. Many of our patients rely on nursing services within the home to ensure an awake and alert caregiver 24 hours a day to monitor their various medical needs. They rely on numerous medical equipment to provide respiratory support ranging from supplemental oxygen to ventilators, feeding pumps for nutritional support, nebulizer machines to receive breathing treatments, specialized hospital beds, and monitors to assess their vitals, to name a few. Families work with various medical supply companies to receive formula and supplies to feed their children to ensure appropriate growth and development, monitors to assess heart rates and oxygen levels, diapers, gloves, and bandages to care for their children. Any delay in obtaining insurance places these children at risk of losing all of these services that are needed to keep them alive, safe, and help them thrive. Our team helps families of children with medical complexities navigate the multiple specialists they see and medications that they require through care coordination. And it is not uncommon for our patients to see multiple specialists within the fields of neurology, gastroenterology, physical medicine and rehabilitation, endocrinology, genetics, nephrology, cardiology, again, to name a few. Similarly, it is not uncommon for our patients to take numerous medications to address the many conditions that they see these specialists and their primary care physicians for. Without active insurance, our families have told us that they avoid going to the doctor because they are afraid of the financial burden that a medical bill will have on their family. I have spoken with numerous families about their inability to afford refills of medications required for the survival of their children due to a lapse in insurance. Furthermore, if our patients don't see their doctors in a timely manner, don't get the medications that they are prescribed, don't receive their equipment at home, then their condition will deteriorate and inevitably they will end up in the hospital admitted. This then creates an undue burden on our already stressed healthcare system. More importantly, this burden is placed on families who are already stretched thin, worrying about how to afford exorbitant medical bills, missing work to care for their hospitalized children, and their families' responsibilities at home. While I was preparing this testimony, my colleague in case management notified me that one of our patients is facing Medicaid termination. The parent applied online mid-October and has placed multiple calls only to be told that their application is in queue. This patient is on 4 seizure medications and is trying to obtain all refills today before they lose their insurance. They also receive nasogastric tube feeds, and until the insurance issue is resolved, this family has been instructed to wash and reuse all feeding bags, syringes, nasogastric tubes for their child to receive their nutrition. I also care for a large immigrant population where an online system presents several challenges for our families who are illiterate or English is not their preferred language. Any improvements to processing timelines for health and social services benefits, reductions in administrative burden placed on parents, and streamlining the process of re-enrollment will have an enormous positive impact on our patients residing within the District of Columbia. I look forward to continuing the discussion on ways to improve the enrollment of health and social services for our patients and their families. Thank you for the opportunity to provide testimony, and I am happy to answer any questions.
Thank you, Dr. Posada. If you could just, for everyone who's testified thus far, please don't go anywhere. I know some of my colleagues are going to have questions. We've been joined by 2 people who were earlier on the list. Danita Moore.
Good morning. My name is Anita.
Anita.
Moore.
My apologies.
That's okay. Good morning. My name is Anita Moore. I'm a resident of the District of Columbia in Ward 7. Aaliyah Moore Bailey is my 10-year-old granddaughter with disabilities and have been receiving Medicaid for approximately 10 years. Aaliyah's Medicaid coverage was approved on July 26, 2023. The system still shows her status as inactive and or terminated. I reached out to the Medicaid office expecting to speak to a supervisor. I waited almost 2 hours with no response, and as of this date, there has been no further resolution in this matter. Thank you.
Thank you, Ms. Moore. Destiny Pelham?
Yes, hi.
Hello, go ahead.
My name is Destiny Pelham. My son is Jace Proctor. He was diagnosed with autism in January. In order to get the Children with Special Needs insurance, we had to, be approved for SSI. I did all of that. So about in August, he got approved for the Children with Special Needs insurance. I do my part, make sure all of my things are recertified, make sure I do everything to keep everything good on my end. The system just kept saying his stuff was inactive. My baby couldn't get speech therapy. He's eating non-edible food items. I'm depressed. I'm sleep deprived. Like it's that bad. And I really feel like it could have been all relieved if, DHS would have done their part. I've been trying to just keep going, trying to do things at home, go on YouTube and learn different ways to help my son, but I'm not specialized in dealing with autistic children. So it's really hard. And for me to keep calling DHS every day, confirming that it's active, supposedly, then I go to the doctor, I receive a bill, then they saying he can't get his speech therapy, he can't get his behavior therapy. It's just a lot. And every day I struggle. I'm stressed out. Like some days I don't even want to get out the bed. But I know I'm a mom and I still have to keep going. So I just do it anyway, but it's a lot. And they have really caused my baby a setback. Like this is a big issue for me. And today they called and told me that it was active, but that doesn't make up for it's not been active since August. He's had the insurance since August and it's now December and he hasn't had not one therapy session, not one of nothing, not anything. So we've just been sitting around just waiting and waiting and waiting. And this is my baby's life. He's only 2. He's walking around eating pencils. He's eating tissue. It's just that bad. And I'm not trying to, sound dramatic, but this is what it is. Every night he's crying from 2 o'clock in the morning to 5 o'clock in the morning from night terrors. I don't have a clue of what to do. Like it's really that bad. And I want them to know y'all they're playing with people's lives. This is a child. This is a baby. He
This is what I wanted to say.
This is the problem. Like this is a
Ms. Pelham, you went on mute.
It said the host had muted me. I'm sorry. So I just stayed on mute, but this is a big problem for me. I'm glad they fixed it now, but that doesn't make up for the hard times and the stress that I've endured since I've been going through this. It's like I had no help. I couldn't do anything but keep calling DHS and asking, is this insurance active, Ms. Pelham? Yes, it's active. Call SSI. He's receiving his payments. I don't even care about the SSI payments. Thank you, but no thank you. I'd rather my baby get some help. Like he's suffering. He suffered. And this is DHS's fault. This is the DC government fault. This is whoever fault where y'all let my baby slip into a hole where y'all just telling me his stuff is inactive when I know for a fact it's active. I stay on top of all of my appointments. Like I'm glad I don't work. I would be at work probably fired. I am sleep deprived. Like this is a big issue. So I don't know. I hope it doesn't happen again. I'm gonna continue to recertify as I should every month every year or however that goes. But this is bad. And this has been bad for me for a long time on top of dealing with housing situations. Like I'm stressed out. I couldn't do anything but just wait and watch my baby continue to go down because he's not getting no help. This is not my fault. Like I feel bad. Like it was my fault. It's not my fault. This is their fault. Something has to be done. That can't be just okay. We can't just keep doing that to these kids. These are children we're talking about, special needs children who need their therapy, who need their help, and they're not getting anything due to DHS.
Thank you, Ms. Pelham. I just hang on for a second because I'm going to ask you some follow-up questions.
Okay.
So we've been joined by Councilmember Zachary Parker from Ward 5. For colleagues, if we just do is a 7-minute round okay for asking questions for this panel of witnesses? Okay, great. So Ms. Pelham, I first off, for you and for Ms. Moore, I'm deeply sorry that this has happened. And I know how frustrating it can be, especially when you feel like you have done your part, you've met the deadline, and the systems are still not processing. Ms. Pelham, you said you received a call yesterday to say that it was active.
Actually, I took my son to the doctor to try to get a referral for his speech. That was on the 29th, so that was Wednesday. I spoke to the caseworker, and she basically was like, give me this information, send me the screenshots of everything being active. I'm going to help you. By Friday, she called and told me that his stuff was active. I called my son's caseworker. Her name is Lydia. She was like, Ms. Pelham is still not reading active on our end. I'm like, okay, I'll give it some time. They just did it Wednesday. Then she called me today saying that it was active. I'm like, well, thank you, but what took so long?
That's correct. So, I think we often hear from a lot of folks who don't realize until they're going to a provider that something is not active or not working.
Mhm.
If you try to make an appointment with your son and you don't, and the system is still reading, please contact our office and we can certainly follow up on your behalf. Ms. Moore, you said your granddaughter was approved in July, but
Absolutely.
but it's still showing as inactive as of today.
Yes.
Okay. I think we have your email address. My office will follow up with you. I don't want you to put all your information out on the street in a public hearing, but we could follow up with you.
Absolutely.
And to work with DHS on that front. But thank you so much for being here.
Thank you for having me.
Ms. Taylor or Ms. Mousley, you both spoke about cases and issues that have gone before OAH, dealing with incorrect payments or things not being processed on time. Would either of you have an idea of approximately how many cases at OAH are pending in dealing with something around benefits?
So I don't have that information, but we can certainly get that from OAH and send it to the council.
Okay, I'm sure we could probably request it as well, but I guess for Ms. Steele, if you're still with us, I imagine that Legal Aid DC deals with a lot of different cases. I'm curious in terms of, if you think about the past year, how many cases have you guys had to take to OAH for something related to benefits?
I'd be happy to include that in my written testimony. I don't want to misrepresent anything off the top of my head, but I do just want to reiterate what Ms. Mousley said, in that many of the cases we are currently taking are cases where everyone agrees on what should happen. And so it's taking up a huge amount of resources for everyone involved and causing a huge amount of hardship. I just want to say that makes up a large percentage of the cases, which we'll include more details on in our written testimony.
The thing that has me concerned is that for both of you, you mentioned, oh, everybody agrees in terms of there's a payment issue or whatnot. And that I think Ms. Mousley, you said, DHS deals with the individual rectification for that particular client, but it doesn't seem as though the underlying system problems are being resolved. And therefore you're having to see this happen again and again. Is that sort of an accurate representation?
Yes, absolutely. And I think what Ms. Steele said was a really good suggestion, right? Like, every time these individual issues are raised, someone should be looking into what has happened in the system for this person to figure out, is this something wrong in the system that's impacting other people? And then fixing that for everybody, because we're, of course, Ms. Steele and I are both attorneys. We can help people. We're concerned about the people that don't have attorneys or other advocates working with them, like some of the folks that testified here today.
Right.
So yeah.
I think one of my frustrations, and it has been for a very long time, right? I don't think anybody should ever have to come to a hearing to get help or to email all 13 of my colleagues just to get someone at an agency to respond. And so if we notice that there is a problem, and then we're also seeing a pattern due to the cases we're seeing at OAH, why not just go forth and fix the underlying issue? Mr. Doyle, you mentioned something that was very interesting in your testimony, particularly around returning citizens or incarcerated individuals, where they have to, quote, submit a proof of release.
Yes.
If I'm not in jail, like what's a proof of release?
I mean, that's a good question, and something we had difficulty even getting clarity on what the document was or where to get it. But again, we were told that it is supposed to happen automatically, and if it really all it is can the Department of Corrections confirm at that moment the person's in or out of custody, and the ESA make that change? That's really what we're looking for, because people have lots of other urgent things to deal with when they come out,
Right.
not just trying to track down.
So this seems like the more streamlined way is that there's a communication between someone who's working at Department of Corrections and someone who's working at ESA. Although I have to say, to do it 24 hours before release also seems like a very short period of time for all of the systems to be updated, especially if someone's on some medications and they need to immediately seek a prescription after they leave. If it takes 48 hours for the system to upload, you know, it may not still be there. Have there been any efforts to do this earlier?
I mean, I'm not sure, because that's supposed to happen not from the from the outside agency provider, but just automatically take place. But that was what I was informed of, like what's supposed to happen.
Okay. All
but
right.
you're centering on the exact concern of why it's so important.
Okay. Yeah, I'm just sort of thinking in terms of like, especially in the number of individuals who have mental health issues, et cetera. If you're on medications, that's something that you need to take in a consistent manner. And if you're waiting for 48 to 72 hours for a system to upload to show that you're not in prison anymore, sometimes a person can get disheartened and just not take it. But also what happens in that 72 hours when you're off of your medication is a problem too. Thank you again for being here. And then Dr. Posada, I wanted to ask about the patient that you mentioned who applied in mid-October and it's still not done. So my understanding of how the process is supposed to work is that when someone is submitting their information for a renewal, once you submit all of the documentation, you are supposed to be in a quote unquote holdover status around like your benefits or your insurance not being cut off, but that doesn't seem to be the case here.
It appears not. The family had mentioned to us that they have been calling and been held on hold for multiple instances, being told that their application is still in queue, which again presents several complications for this patient in particular, being that they're on multiple seizure medications. And as you just mentioned before, those hours, minutes that you are off of those medications that are essential for keeping their child safe, seizure-free, and alive are not being received. And so we have to kind of help them navigate in the moment ways to obtain medications prior to these lapses in insurance, making sure that they get their formula and other necessities before any lapses in insurance occur, and then work with them to see how we can help to expedite the process.
Okay. I appreciate your testimony for being here today. I know there's obviously doctor-patient privilege. And so if you want to refer that patient to our office, we can certainly try to help intervene if we can. But I'm over my time. Councilmember White.
Thank you, Chairperson Henderson, and thank you to this panel. Let me start with Rebecca Steele. For people doing renewals, do they continue to receive their benefits as these issues play out?
In our experience, they typically do not. So as was just mentioned, in a Medicaid, you should have the holdover, but in a lot of cases, we're seeing that if it's not processed in time, it's a mix, but in many cases, it's just a termination. And the same thing goes for SNAP and TANF. If there's an issue with the recertification, that typically just leads to a termination. And then the person will not be receiving any benefits whatsoever until the DCAS error is resolved.
Okay, so you're in your experience, it is not the case that while people while renewals are pending, most people are still receiving benefits.
That's correct.
Now, one of the things that we're hearing from DHCF is that the district has some of the highest overall passive renewal rates in the nation, which to me implies, we haven't heard their testimony yet, but implies that renewals are happening more or less automatically without a lot of effort from residents. How does that coincide with your experience?
So the problems that I've been seeing are for folks who are not eligible for the passive renewal system. So I personally, speaking only for myself, have not had cases where the passive renewal has been causing problems, but it's in the case of folks who do need to submit that additional documentation and need to be involved actively in the recertification process where problems arise. And in the case of Medicaid, it's often just that it's not processed in time or there's some glitch with how it's uploaded.
And who would need to submit additional information as opposed to passive renewal?
I believe it based on the information the district already has, if they need any additional information, a passive renewal would not be appropriate in that case.
Got it. Thank you. Anybody on this panel, can anyone on this panel speak to improvements in the system that you've seen over the past 2 years since it's been active? All right. Does anyone on this panel work on these issues in other jurisdictions outside of the district? Trying to understand if other states use the same technology and if they are seeing the same issues. Dr. Posada, do you have any familiarity with what's happening in other jurisdictions?
Not to the same extent that I do with DC Medicaid, being that I'm primarily within the District of Columbia.
Okay. And this will probably be for some of the legal service agencies, but do you know if people's eligibility status in the district direct system matches their eligibility status in SSA?
I'm not sure what you mean by that. I do know that eligibility status in district direct does not always actually match their actual eligibility or receipt of benefits.
Do you happen to know, Ms. Steele, how much advance notice people receive about benefits being terminated?
That's unfortunately a wide range. I think that there are issues with DCAS. Obviously, we have a limited time, so we couldn't bring up every issue, but there are issues with DCAS not generating notices when it's supposed to as well. In a lot of the Medicaid cases, as has already been alluded to, there is no notice ever issued. Someone finds out just by going to their provider and is then informed that actually the coverage is not active. And with SNAP and TANF, it is a real range. Sometimes a notice is issued on time, but it has just incorrect information saying that they're going to be terminated when they shouldn't be. And sometimes it's issued with less notice. So that's to say it is a real range, but often there is not sufficient notice for someone to be able to fix the DCAS error in time, because it takes so long as well, even if someone does get notice.
One of the things points you made in your testimony that I appreciated and I hope people heard is that even if and when issues get resolved, that doesn't fix the nights that folks were hungry or couldn't access medical services in the weeks and months prior. For SNAP, if someone has an issue with their eligibility or renewal and it takes 2 months to resolve it, it's resolved in favor of the resident, do they get back benefits or does it just start at the time that the issue is corrected?
If the appeal was filed on time and the issue is largely the fault of the agency, generally, if someone goes to the Office of Administrative Hearings and gets a favorable order from a judge, that judge will usually include the back benefits. But for someone who does not have the resources to be able to take the case that far, they may not get that relief that they should be entitled to. And even when that relief is ordered, as Ms. Miles Lee and I have discussed, it's very difficult to get the agency to comply on the deadline by the deadline set, because sometimes we have cases where that back payment has been ordered, but the agency is not issuing it, again, due to a DCAS error. So theoretically, folks should be able to get those back benefits, but that's not always the case in practice.
Thank you. The last thing I will say, Councilmember Chairperson Henderson spoke to Ms. Moore and Ms. Pelham, and it sounds like it's going to help get those issues resolved. I'm happy to assist as well, but as Chairperson Henderson said, people should not have to sign up for testify at a public hearing and air out their problems in order to get help. To Ms. Moore, with a 10-year-old grandchild, that is an incredibly difficult situation to navigate on its own, even without these types of issues. For Ms. Pelham, having a 2-year-old dealing with these issues that require timely treatment, you know, the stress and anxiety that you're expressing in your testimony are very real, and I think humanize this issue. It is not just a waste of hundreds of millions of dollars. It's not just a system that isn't working. It's real people and children who are having issues here. So thank you for being part of this hearing. Thank you, Chairperson Henderson.
Thank you. Councilmember Parker.
Thank you. As I came in halfway in this panel, and I am eager to get to our government witnesses, I'm going to pass on questions, but I would just echo what has been shared. Ms. Moore and Ms. Pelham, you offer very compelling testimony, and I, especially Ms. Moore, am hopeful that your work with the committee can rectify the situations that you highlighted. And Ms. Pelham, I agree, it shouldn't have taken this long. And so there will be some follow-up questions for our government witnesses when the time comes. Thank you.
Thank you, Councilmember Parker. And thank you to this panel of witnesses. If you have not submitted your testimony for the record, if you could do so on the council website, it's just really easy to just upload and submit. We just want to make sure that we have a full accounting. All right, we will go on to the next panel and final panel of public witnesses. Stephanie Maltz, Claudia Schlossberg, Sam Crane, Lindsay Niles, Alex Orion, LaJoy Johnson Law, Tatiana Nova, and Claudia Jackson. Give it a minute as we transition and bring those folks in. Again, for those who are in the waiting room waiting for your opportunity to speak, you'll get a prompt that invites you to be promoted to a panelist, and you have to affirmatively accept that in order to testify. For those who are on the first panel, we'll put you back in as a general viewer for this hearing. Okay, I don't see Ms. Maltz, but I do see Claudia. Claudia, if you want to go ahead and present your testimony.
Absolutely. Thank you so much. Good afternoon, I guess good morning. Good morning, Chairpersons Henderson and White, and Councilmember Parker, and members of the Committee on Health and Committee on Housing. My name is Claudia Schlossberg, and I serve as the Workforce Development Committee Chair for the DC Coalition on Long-Term Care. This is the third time I have testified regarding challenges associated with Medicaid applications and renewals, specifically as they impact seniors and people with disabilities, due to the design and management of the application and renewal process, DC direct limitations, and policy decisions limiting who can access DC direct and the consumer-facing portal of the DCAS system. In May, I testified that the Medicaid renewal process likely would disproportionately impact the 63,000 district residents whose Medicaid eligibility is determined using non-MAGI income methodologies. At that time, I explained that for approximately half of those individuals, according to DHCF, passive renewal would not be an option, because when these seniors and people with disabilities were integrated into the new DCAS system, only very limited data from the old system, ACEDS, was converted. As a result, to complete the renewal process, non-MAGI seniors and people with disabilities effectively must reapply for Medicaid using a 44-page application form. And for those needing long-term care, they need to complete an additional 18-page long-term care supplemental application form, a total of 65 pages. By design, these lengthy application and renewal forms and the documentation needed to verify eligibility factors for those beneficiaries can only be submitted in one place, a new partner portal in DC Direct, and only a very limited number of providers have privileges in this portal: hospitals, nursing homes, ICFs, our new PACE program, United Healthcare, DACL staff, and EPD waiver case managers. This means that for approximately 5,500 seniors enrolled in the EPD waiver, Only their assigned case manager can complete and submit the renewal form and submit supporting documentation. If the assigned case manager fails to complete the process timely, the resident loses Medicaid and no one else can submit the form for them. This not only leaves the resident vulnerable without access to health care and needing long-term care supports, but it in my opinion, violates both federal and district rules on eligibility processing. As the renewal process unfolded earlier this year, it was clear that DHCS system design and management of the renewal process was failing these beneficiaries. DHCF's own data consistently has shown that district residents 65 and over and people with disabilities are losing coverage for procedural reasons at far higher rates than other beneficiaries. In a large percentage of cases, the assigned case manager failed or has been unable to complete and submit the renewal form. In October, DHCF shared that 16 out of 18 case management agencies were out of compliance with the requirement to assist EPD waiver beneficiaries with the renewal process. These 16 agencies serve 96% of the EPD waiver population. Instead of rethinking business processes, simplifying the forms, and opening the partner portal to others who can assist these beneficiaries, DHCF mandated more training for these case managers, failing to recognize that no amount of training will fix this flawed design. As I testified in September, these procedural terminations have immediate impact on the ability of beneficiaries to receive ongoing needed health care. For those receiving long-term care, once terminated, providers cannot be paid for ongoing needed care. They also have limited access to information as they lose connectivity to the DC Care Connect system. They have no ability to submit forms on behalf of the beneficiary. They're spending hours making phone calls. You've heard other stories and other testimony today, sending emails and elevating cases to DHCF. It can take months for cases to be resolved. And one provider reported last September they had 14% of their current census in non-pay status due to the failure to renew Medicaid timely. This involved a total of 483 days of care that they have been providing with no compensation, and the amount at that time owed was over $100,000. In addition, this provider was covering Medicaid billable costs for residents who lost coverage, including, for example, transportation costs for one resident who needs life-sustaining dialysis 3 times a week. Since September, this provider has informed me that the number of residents in non-pay status has doubled. We have written multiple letters to DHCF and have raised these concerns in numerous meetings. We understand that complex IT systems and business processes cannot be redesigned and deployed overnight, and that DHCF very likely would need to seek CMS authority to make some changes. But doing nothing is not an option. While working on longer range plans to fix DCAS in the application and renewal process, DHCF needs to develop and deploy workarounds to allow the manual processing of renewal forms by anyone who can assist the beneficiary to complete the form, manually updating program codes that need to be corrected, and designating DHCF staff to complete case management tasks that are needed to maintain access to services like completing person-centered plans and requesting PAs. I'll conclude by saying, bear in mind that we are only 8 months into this renewal cycle and only 5 months away from having to start it all over again. If DHCF is unable to remediate the issues that are contributing to such high rates of procedural terminations, we are recommending DHCF seek authority from CMS to suspend renewals until remedial measures, including interim measures, can be put in place. Thank you for the opportunity to testify, and I'm happy to answer any questions.
Thank you. I do not see Sam Crane, but I do see Lindsay now. Lindsay?
Good morning, Chairperson Henderson and White and Councilmember Parker. My name is Lindsay Niles, and I'm a managing attorney at Disability Rights DC at ULS. DRDC appreciates the opportunity to testify. DRDC is the designated protection and advocacy program for people with disabilities in DC. DRDC remains concerned about DHCF's DCAS design choices that discriminate against people with disabilities. These choices have contributed to a low renewal rate for people with disabilities, a high procedural termination rate, and untimely and erroneous processing of pending renewals. You may also refer to my written testimony, which addresses these areas in detail. DRDC sent letters to DHCF and the deputy mayor most recently on October 25th regarding these issues. We requested that DHCF make changes to its system, including DCAS, to reasonably accommodate these persons with disabilities. DHCF has failed to respond to our October letter. DHCF's lack of response is very concerning given the consistently troubling renewal data. At a rate of 43%, people with disabilities and seniors with renewals due May through September have had lower renewal rates than other Medicaid groups to date. This means that 57% of beneficiaries may face termination. DHCF has reported that approximately 4,700 non-Magi beneficiaries were procedurally terminated or at risk of termination as of October. DCAS policies and procedures have contributed to the untimely processing of Medicaid renewals and procedural terminations in some of the following ways. First, DHCF erected barriers to effectively collecting renewal information because DHCF transitioned to an updated DCAS system without manually transferring long-term care beneficiary information into the updated system. The timing of the transition exacerbated the challenges because it updated systems before the end of the continuous enrollment requirement. As a result of DHCF's failure to transition this information, DHCF requires people with disabilities to essentially reapply for Medicaid and submit longer renewal forms than people without disabilities. DHCF should streamline renewal forms and requirements for this population and should manually enter information from its legacy system into District Direct. Second, DHCF's regulatory procedures, which place the responsibility on case managers to complete Medicaid renewals, also impacts time and completion and processing of long-term care renewals. Additionally, long-term care renewals must be submitted in the District Direct Partner Portal. As a reasonable accommodation to reduce delays in receiving and processing renewal applications, DHCF should develop a plan to change the systems and policies such that an individual may access their renewal and submit information on their own or have help from a case manager or other assistance of their choice. DHCF is tracking renewal timelines by waiver case managers monthly, but it fails to act to protect this vulnerable population. As Ms. Schlossberg noted, there's significant neglect of 16 case manager agencies for the EPD waiver that serve 96% of the waiver population. DHCF should stop procedural terminations for this population that would otherwise occur due to a non-response until DHCF can remediate these systems issues. We again urge DHCF to increase DHCF staffing to provide one-on-one help to recertify everyone that has not responded. Third, we also remain concerned about DCAS's system issues that result in automatic terminations when renewals are timely submitted. Despite the district's policy that timely submitted renewals will be placed in a pending status and Medicaid coverage will be extended to allow for ESA processing, DHCF acknowledges that there's still gaps in coverage. We urge DHCF to modify its system to automatically identify that a renewal is pending and automatically stop that termination. A DRDC client faced termination because ESA is failing to timely process his renewal, and DHCF did not manually extend his coverage while this application was pending. James is a 52-year-old man with ALS and quadriplegia. He's on the EPD waiver and totally dependent on 24 hours of PCA and skilled nursing services for his ventilator and trach care, as well as all activities of daily living. James contacted our office requesting legal representation in his OAH Medicaid appeal. He only learned that his Medicaid benefits were about to be terminated on October 1st because his MCO, United Healthcare, called him the day before the termination would go into effect. Neither James nor his case manager received a termination notice. We contacted DHCF and confirmed his waiver case manager timely submitted his renewal application on July 20th and submitted a follow-up inquiry concerning ESA's delay after the 45-day processing period had passed. DC Direct shows his Medicaid is inactive instead of pending status, and his renewal has been pending for more than 60 days. We urge DC Council to hold DHCF and DHS accountable to stop these practices and remediate the harm to this population to maintain their health and safety and remain in their community. Thank you again for this opportunity to testify. I'm happy to answer any questions.
Thank you. Alex?
Good morning, Chairperson Christina Henderson, Chairperson Robert White, and DC Council members. My name is Alex Aurelian, and I am the Health Administration Manager for HCC Home Care. HCC Home Care is a nonprofit healthcare organization committed to serving children with complex healthcare needs and eliminating barriers to health services in the District of Columbia. We have discovered in the past few months that a lapse in insurance coverage is frequent as compared in the past years. We had a client recently where it took almost 2 months to resolve a coding issue which impacted the patient safety and care. This client was to receive from 8 to 16 hours of skilled nursing per day, which is essential to the patient's well-being. We have even another client which insurance coverage has still not been recertified, and I continue to receive several calls from the family every day. In addition to these 2 clients, we have several other clients that we care for and provide coverage, which insurance is ending. Some of the clients requires skilled nursing up to 16 hours, included but not limited to G-tube, tracheostomy, and ventilator dependent. If the client does not have insurance coverage, unfortunately, HCC Home Care is unable to provide staffing coverage to relieve these families which they desperately need. Several of the families that we have no idea how to recertify their insurance coverage. It is a burden for most of them since they have to care for a child with complex needs. Any delay in renewing insurance coverage for these children affect their care and safety. We hope the DC office can find a way to better assist these families in renewing their insurance coverage. Thank you for this opportunity to testify today. And if you have any question, I'm happy to answer. Thank you.
Thank you. Ms. Johnson-Law?
Good morning. Can you guys hear me okay?
Yes, good morning.
Good morning. All right, let me make sure this volume is turned up. Okay, sorry if you hear my kid in the background. We have a pulmonary appointment today, so I'm going to try to be brief. Good morning, Chairperson, Councilmember Henderson, Councilmember White, Councilmember Zachary Parker, and other members of the council. My name is LaJoy Johnson-Law. I am a proud Ward 8 resident. I'm a disability rights advocate, special education advocate, and I have many titles in the community, but today I'm here in the capacity as Abria's mother. Abria is my 12-year-old baby. She is a child that has complex healthcare needs. You probably hear her singing. She was born, many of you know, some of you don't. My child was born at 1 pound, 6 ounces, and she was born at 23 weeks. So we have neurological concerns. We have respiratory concerns, which is what we're dealing with today. We have an ENT concern. We have a cardiology concern. On top of the pediatrician, the child is on daily medication. I'm not even going to name them all. It's too much. It's at least a good 7 just to keep her at a stable place. My turn? My turn. Thank you. Hold on a second. My turn. Thank you. And this is a child that receives OT, PT, and speech in school. This is a child that receives PT, OT, and speech outside of school. So Abria is also a HSCSN enrollee. And in October, I received a letter from DC Healthcare Finance stating, hey, Ms. Law, your eligibility changed with SSI. So we went through our normal SSI re-eligibility termination. They decided that, hey, Ms. Law, you make a little too much money. I didn't realize that $40,000 meant that that's a lot of money. I can't even pay my rent with $40,000. That's another story for another day. Anywho, so they said, hey, Ms. Law, yeah, like you got 14 days. Okay. So your child's being cut off. You got 14 days. And through those 14 days, 7 of them, Abria and I were actually homesick. So by the time I got to this, it was really only 7 days. I call her case manager at HSCSN and they said, yeah, Ms. Law, like she's set to expire at the end of the month. And I said, well, wait a second, like, well, what do I do? No one really could tell me the pathway to getting her situated. We had to call the social worker. We had to call her doctor to do it's called a provider referral. So we had to do the provider referral. Then we had to expedite the provider referral because Abria is also in the middle of evaluations with her PT, OT, and speech. She's on numerous daily medications just to keep her situated. And I'm just like, what am I going to do? Like, I don't have any other insurance for her. Like her needs are way too great. Like I can't put her on my little jobs insurance. Like that's just not going to fly. That's not going to work. Right. And so they said, okay, we're going to put in the provider referral. They put in the provider referral. Thank you, Maud and Colleen at DC Healthcare Finance for helping us through the process. So we got her temporarily approved. The other part of this issue is that she's set to expire in February. And I still have not gotten a real answer as a pathway to move forward. Like, am I supposed to do Katie Beckett? Like, am I supposed to, I submitted the forms to DHS. By the time they said, hey, like, you're going to get off, you're not going to have coverage in 14 days. Make sure you put in your forms. I put in my forms. I emailed the social workers and everybody at the hospital, her care manager, saying, hey, like, this is what I did. I haven't received an answer, so I don't really know what's going on with that. I'm still, again, just waiting on guidance, because this is a child that was enrolled under one category. Now she's in another category. Now she's in a temporary category. And it's just kind of like, I don't really know like a clear pathway of how to move forward. But my request is that when these things happen, is there some type of waiver or some type of holding pattern or some type of holding period where families can just say, hey, we're in the middle of a change, so can we give it 60 days? Is there a way for DC Healthcare Finance to sit down with families and to hear like what is happening, to come up with solutions? Is there a way for DC Healthcare Finance to designate a specific team, maybe to CASIP or to something else? Like, I know you all have heard this, but like, this is really life or death for my kid. Like, I cannot afford to lose her insurance. I can't afford it. I'm a single mother. I work several jobs. She cannot go without insurance. I won't have a child. And people may think that's extreme, but it's not. That's what we're going through as caregivers of our kids with disabilities. And we keep having to come to these council hearings and everywhere else screaming from the rooftop saying, hey, can you see us? We're struggling. And I just pray that like we can come up to some resolution today, because it's not okay.
Thank you, Ms. Johnson-Law. I don't see the final two folks who are on the witness list, so we'll just move to panelist questions. Ms. Johnson-Law, I want to say I hear you, and I think that you are not alone in terms of parents who are looking for whatever the particular pathway is, where you don't have to sit on a phone or call a caseworker and a social worker and 5 or 6 other people just to get a response or to something. There's some other folks who are on the witness list who aren't here to testify in person, but who have submitted testimony for the record in the portal, which I read, and it was parents who had similar concerns as you. They were informed and then said, you have 14 days to find a new whatever in order for your child to continue coverage. And so we'll ask some questions on that today. Ms. Schlossberg, I wanted to ask you a couple of questions, because you're very uniquely positioned here as any more than others on the panel. Were you working at Healthcare Finance when we first started the DCAS process?
Yes, I was. I started working at DHCF in 2011, right after Obamacare was enacted. And I worked on actually getting the funding to help fund the DCAS system, and continued to work on it pretty much throughout my tenure.
Okay. And so for some of the problems that we're hearing from the public witnesses testifying today, did you see this coming? Were any of these issues raised in those initial iterations of what would become the district direct system?
Yes. The implementation, the design and implementation and deployment of DCAS was always challenging. And there were also initial problems. In fact, at one point, the district, I think it was part of the Salazar lawsuit, was sued. We had, trying to remember exactly, but we had to suspend renewals for a period of time while we were building and deploying the initial system. And when we turned them back on, we had serious problems. And so we had to respond to that. I would say one of the things and one of the roles that I played within the agency is that twice a week, I met with the DHCF, DHS, DHCF policy team, as well as the IT teams, to try to both do root cause analysis of problems, to identify systemic problems, respond to the problems that were raised to us. But then we also had to put in remediation plans to address issues, to correct the issues as they were coming in, including manual processing.
Okay.
I mean, it was extremely challenging, but it also required pulling resources together from both agencies as well as the IT team.
Is this a situation where has it always the DCAS IT build out and overall maintenance, has it always been something that we've done in-house with Octo, or was there an outside vendor at a period of time?
There were various outside vendors. I'm not familiar with the current group of vendors that are working on the system. I've been out of the agency for 5 years.
Okay. No, well, yes, I know that part, but okay. I'm just trying to look, when I originally saw the price tag of how much we have spent on DCAS over the years, right? Like,
yeah,
we added up. That's multiple baseball stadiums and some other things. And it's still having significant challenges and issues. And I am worried that it's like a too big to fail now situation where like we've spent so much money on it and we've got so much invested in it that we're not going to pivot, even though it may not be serving residents in the way that it should be serving residents. And so that's a worry that I have here. Ms. Niles, I wanted, if you're still here, I wanted to ask you, you talked about the transition to DCAS and healthcare finance, not manually moving the long-term care data over, but choosing to have everybody redo it. Prior to this decision being made, were advocacy groups, disability rights groups informed that this was going to be happening?
DHCF did issue some public notices that they were switching over to DCAS, but we were not aware that the long-term care population was essentially left behind in terms of the limits, in terms of the information that they transferred over. But they generally did notify the public that they were moving towards this new system or updated system.
Okay, but did they provide any rationale as to why the long-term care data was not moved with everything else? Was it just because it was more complex? It was going to require a significant amount of data entry. It seems to me having everybody start over was not the most efficient way to do. It could have been the most efficient way to do it, but in terms of continuous coverage, it was not the most effective way to do it.
Yeah, I absolutely agree. And I think that would be a really important question to ask the deputy mayor today and about why those decisions were made. I don't know if Ms. Schlossberg has anything to add about this, but I think that's a very important question.
Okay. I want to thank everyone else for being here. I don't have any other specific questions for this group. Chair White.
Thank you very much to this panel. Ms. Johnson-Law, you've been dealing with these systems for a number of years. The current district direct DCAS is about 2 years old. Over the past, let's say 4 or 5 years, what's better in terms of your experience and what's worse?
So, not to sound crude, but I really haven't had a better experience. That's like the other part of my issue was when I was instructed to go into district benefits, there was a lot of information that was like incorrect. So when I tried to update it, it would not let me update it. It wouldn't even let me say that Abria is a disabled individual to complete a new application. I had to physically fill out the application, take it down to one of the DHS service centers. And as of today, I still don't know the status of that. I really don't. I'm trying to figure out a pathway forward, whether that's Katie Beckett, everything is set to expire in February, but at least that's 60 days away instead of someone telling me, hey, you have 14 days. Maybe the council can look at the regulations to see maybe can we extend the 14, maybe at least to 30 or 45, just to give people a window to go from, to get things situated if you're moving from one category of eligibility to another.
14 day. And what do you need to submit in that 14 days?
So when I got the letter, it was saying, hey, Abria has lost her SSI category eligibility. So when you have SSI, it's like it's kind of like an automatic eligibility. But when you lose it, you need a provider referral, or you need some type of other referral to take you through the system. So the 14 days is to say, hey, you're not in this category anymore. Submit your Medicaid just submit your Medicaid application. You can do it through district benefit, or you can take it to one of the service centers. District benefit was not working, so I took it down to one of the service centers. But again, they still have to process everything. So I don't even know if it was actually processed within the 14 days. In my case, what ended up happening was the DC Healthcare Finance approved her provider referral as a temporary form of relief, I guess, while I continue to go through the process.
So if you have to submit something in person, are there options to do that in the evenings or weekends?
No, sir, not that I'm aware of. You have to go to one of the DHS service centers when they are open to the public. So just their normal operating business hours, I believe. If there's something else outside of that, I was unaware.
Okay. So with a $600 million investment in a new system, as a user, you would say you don't notice any benefit to you. It's no easier.
The way they designed it online is like, oh, okay, like I see, like navigating it was like, okay, I see where they change your household, update your household, put in a new application. That part was okay. But I wasn't able, when I would go into certain features, I wasn't able to like update my household. I wasn't able to say Abria is a disabled individual. And when I was talking to Maud from DC Healthcare Finance, who was very helpful, she instructed me, she said, you cannot do this application without indicating that she is a child with a disability. You have to indicate that, because that changes, I guess, not the aura of the application, but like the application needs to know that, hey, I'm applying for a disabled child, because I guess there's a different pathway. Right. So.
All right. Thank you.
Thank you, Councilmember White.
Ms. Schlossberg, I appreciate you being with us. Do you know why it seems like the district is having much deeper issues than other states?
I actually can't speak to the current situation in other states, but I do think that we are having some significant issues, as you've heard from testimony and I'm sure from other constituents. Again, I think that some of the design issues, the way the system was designed, for example, the online portal, these things have to be designed with the end user in mind, right? And if the end users aren't involved, or decisions are made, then it can be very difficult for consumers, for people trying to access the system, for their children, for their parents, or it can be very difficult. So there have been design issues. There's also management issues, and again, as I said earlier, these systems are never easy, and there's almost never a deployment of a new IT system where there are not problems. But the issue is, what is the response to the problems? Is there a willingness to acknowledge system issues and to be proactive around resolving them, and to do it timely? One of the issues that I hear about is, for example, when there's a code issue, a code isn't updated, the program staff will send that on a ticket to the IT team, and then it just sits in a queue, instead of someone then manually going in and changing the code so that the service can be provided. So there needs to be both that underlying willingness to acknowledge problems and fixing them, both at the systems level and then dealing with the immediate need to address the issue for the beneficiary.
To your knowledge, are there meetings with end users?
Not that I'm aware of.
One final question, because of your work in the initial stages of this of DCAS. So the federal government provided, I think, a 90% reimbursement for developing the system. Was it anticipated when the systems were being developed that the cost share would be different for operations?
Yes, that's always been the case. Design, DEI design, implementation development is 90%, and maintenance of IT systems, I believe, is either 70 or 75%.
Okay, so we knew when we were building the system that the reimbursement rate would be lower for operations.
Yeah, operations and maintenance is reimbursed at not the percentage is lower. Yes.
Okay. Thank you so much to this panel.
Thank you, Chair White. Councilmember Parker?
Yes, thank you. Ms. Johnson-Law, again, heart-wrenching testimony like we heard on the last panel. I just want to make sure we're clear. It seems like you're in a temporary holding spot right now. And it seems like at a time certain, I believe you said at the end of the month, that temporary status will expire.
So the temporary status is set to expire the beginning of February. And so I'm just trying to figure out, like, do I need to go the Katie Beckett route? Like, I honestly don't know, and I'm still waiting on an answer because I was in an enrollee. I'm now disqualified and got dropped. Then they were going to start her, and this was at the end of October. Then they were going to say, oh, she got approved, but it's not going to start until December. That's unacceptable. That's not going to work. So I literally begged, like, hey guys, can you please just, this is in the social worker, like, can we please just push this to November so she does not have a gap in coverage? They approved her, said, okay, we'll start this in November, but it's set to expire in February. And I don't know what to do. Honestly, I don't know.
We will lift this up when the government witnesses come, and I'm happy to work with the committee to get specific answers to you. But it also seems like your case manager has been unsuccessful in getting information. Is that accurate?
When you say information like regarding like DC healthcare finance, do you mean
path forward, as I think you put it? No one.
Yes, she. The only pathway she knows is, okay, Ms. Law, like, you have to go through Katie Beckett. I think what's different about my case is if I'm already enrolled and then you kind of get dropped and then you kind of get like re-enrolled as a temporary case, like, what is that pathway and what does that look like? And I think maybe that's where the disconnect is. This is one of those kind of like weird different situations because most people are trying to come in from the front side to get the insurance, to get through. I'm coming from, she's already enrolled, now she's dropped, now she's temporary enrolled.
I got you. I will endeavor to get an answer for you in today's hearing, and I'm happy to follow up with you.
Thank you. Thank you so much, Councilmember Parker. Thank you.
Your very candid testimony. Ms. Schlossberg, I wanted to come to you. You talked about the seniors that are on the EPD waiver, some 5,500 seniors. There are several issues. One, many of them are not eligible for the automatic renewals, but also you're highlighting that if their case manager does not re-enroll them, they lose coverage. Do you have a sense of how many seniors that maybe you worked with or have heard about that has lost coverage because case managers are not actually following through on the process?
I believe that number, I don't have the number off the top of my head. I think Ms. Niles may have mentioned it in her testimony. DHCF is tracking some of this information and shares it in their monthly meetings, but unfortunately, I just don't have that number. I know they did share with us at a recent meeting that 16 out of 18 case management agencies were under some sort of corrective action plan because they were not meeting their obligations. And again, I will say that some of the case managers are very diligent and trying very hard to do this work. It's not easy, particularly since they have to gather so much information from individuals who often or may not be able to help them in terms of being good informants or knowing where their documents are. And other case managers simply aren't doing their jobs. But we know that 16 out of 18 of the case management agencies are under some sort of corrective action.
And I do want to come there next, but Ms. Niles, do you have that number of how many seniors that are on the EPD waiver that are losing coverage because a case manager did not follow through the process?
So in terms of we don't have the data narrowed down in terms of the reason for the termination, but we do know that from folks that are due May through September, that approximately 4,700 non-MAGI beneficiaries, so that includes seniors and people with disabilities, were procedurally terminated or at risk of termination as of October of 2023. And as Ms. Schlossberg mentioned, any individuals that are on the EPD waiver or receive long-term care services and supports would need their case manager to complete the renewal. And so there is a subset of that population that have been terminated. My written testimony also points to the presentation that DHCF presented with this data as well. So you can refer to my written testimony.
Awesome, thank you. And I wanted to come to that number of 16 out of 18 case management groups that are, let's say, not in compliance. And it seems like the status quo is let's focus on training, let's get them back on track. But both of your testimonies, Ms. Schlossberg and Ms. Niles, is around we need systemic changes. Ms. Niles, I heard you talk about we should stop the procedural terminations, establish one-to-one help. When you shared these recommendations, what has been the response, or have any of them been acted on up until this point?
No, we wrote a letter in July, and there may have been a second letter. We did get a written response from DHCF, and essentially they continue to support solely relying on case managers to submit applications in the DC partner portal. And again, this really narrows the ability, who's able to help and where the information can be submitted. So they did respond, but they basically said they were responding with no changes.
Understood. Okay.
Go for it.
So also in terms of your follow-up about our request that they stop procedural terminations for this population and provide DHCF staff to provide one-on-one support, I just want to add that, as I mentioned in my testimony, we did send a follow-up letter to DHCF in October, and we have not received a response to that letter. We have met with DHCF one time to discuss these recommendations, which are supported by guidance by CMS, that DHCF does have the flexibility to seek approval to stop terminations until they can figure out these systems issues. But DHCF so far has declined to implement these flexibilities for this population to protect their health and safety.
Thank you. I am over time. Thank you for your testimony.
Thank you, Councilmember Parker. And again, thank you to this panel of witnesses. If we do not have your testimony for the record, if you could please provide that online. We'll now go to our government witnesses. Laura Zeilinger, who's the Director of the Department of Human Services, and Wayne Turnage, who is the Director of the Department of Healthcare Finance and the Deputy Mayor for Health and Human Services. I invite both of them to join us at the table, as well as a shifting of people. Guys, Shell's turn. Come on over. As they make their way, Good morning to you both. And I guess, well, let me see here. Okay. Okay, so before we begin, I will ask for you and anyone on your team who might speak today to be sworn in, that their testimony is going to be accurate. So if you could raise your right hand. Wonderful. Do you swear or affirm under the penalty of law that the testimony you're about to provide to the Council of the District of Columbia and these committees are the truth, the whole truth, and nothing but the truth?
I do.
Great. You may begin your opening statement. I'm not sure who's going. I think Director Turnage, are you going first?
Yeah, yes.
Okay, great. Go ahead.
Good morning, Councilmember Henderson, Councilmember Parker, and any other members of the committee or the council that may join. I am Wayne Turnage, Deputy Mayor for Health and Human Services and the Director of the Department of Healthcare Finance. I am joined at the table by the very capable leader of the Department of Human Services, Laura Zeilinger, my Director of the Medicaid program, Melissa Bird, and our Manager for the Integrated Eligibility System that has been discussed, Tamika Fitzgerald. We are quite pleased to have the opportunity to discuss the District of Columbia's access system, which we call DCAS. As shown on slide 2, the focus of my remarks today and our remarks will be on the history and performance of the system, along with a discussion of our future challenges and priorities. But let me say at the outset that the design, development, and implementation of DCAS has been an expensive and challenging effort spanning more than a decade. And our work is not yet complete. But make no mistake about it, DCAS is a considerable improvement over historical eligibility processing in this city. A fully integrated system that has multiple routes for access, that empowers residents to manage their benefit accounts, and greatly reduces processing time for both residents and caseworkers is an unquestioned accomplishment, notwithstanding the difficult path to development and the remaining challenges that we face. In the interest of time and recognizing the committee's concentration on the issues surrounding case processing, I will move quickly through the slides to be sure to leave time for the committee's questions. If you turn to slide 3, you'll see that the Affordable Care Act was the catalyst for the development of integrated eligibility systems, which pushed down to the states as a part of a larger plan to significantly expand Medicaid. And DCAS was born in this environment. HHS translated these broad policy goals for ACA into action in 2 important ways. First, as slide 4 discusses, HHS allows states to expand eligibility for Medicaid up to 133% of the federal poverty level. Second, HHS announced guidance to help states design and implement the information technology needed to establish market-based exchanges and help enroll people who qualify for Medicaid or the Children's Insurance Program, tax credits or cost sharing reductions that are available through the ACA. Conceptually, the technology envisioned the following: a movement away from paper-based reactive eligibility processing, a movement towards a more modernized and efficient process by requiring states to use electronic data matches to determine eligibility for benefits and tax credits, and the creation of a single integrated application so an applicant could apply for the benefits in one pass through the system, or all benefits. We are here because the district chose to exploit these opportunities by fully integrating eligibility processing, including the use of data matches and other strategies to make real-time eligibility decisions as highlighted on slide 5. Let me say that there are not many states that combine both a fully integrated eligibility processing system with real-time determination of benefits. We are in a small number of states that have pursued that much more complex, much more expensive, and hopefully at the end, much more effective eligibility system. The district, as shown on slide 5, as I've stated, It gives you a picture of what we do differently compared to what we used to do and based on what we do now. Now, if you look at the right side of that graph, it shows you that other states will collect information for all programs, but don't necessarily execute eligibility in real time. In those states, eligibility determination is made by caseworkers using the information they receive to process the individual's case. If you go to slide 6, the development, oversight, and management of this complex system has been, by admission, over a 10-year period, rather meandering, at times tortuously challenging. And I won't punish you with all the details of that 10-year flight, but the outline of the route to where we are now and the agencies involved in getting us here are shown on slide 6. The key points to take from that slide, when I came to DHCF in 2011, we had no IT infrastructure. So we developed an MOU with DHS, who had a much more advanced IT system in place to design and develop the system. Concomitantly, HBX under Mila Kaufman worked on the market-based exchange and the eligibility processing for Magi Medicaid as Release 1. Octo assumed control of the system for a very brief time and continued to work with DHS on the development of Release 2. Finally, DHS assumed responsibility for the outstanding development issues and the oversight of the system in 2018 to present. Slide 7 shows you how the development of the system has evolved over a 9-year period with in 3 releases. First one being Magi Medicaid and the exchange, DC Health Link. The second release being cash and food benefits, and the third being non-Magi, mostly long-term care and other programs. Slide 8 illustrates how DHCF interacts with our sister agencies to implement this system. In short, DHCF, DHS, and HBX are currently in partnership with distinct areas of program and system oversight responsibilities that are essential to the function of the district's integrated eligibility system. DHS, SNAP, and TANF, application processing for SNAP, TANF, Medicaid, and Alliance, the Immigrant Children's Program. DHCF, we provide oversight to the entire system, and we set policy for Medicaid, Alliance, and the Immigrant Children's Program. And HBX does the oversight and management of the policy, technology, and application processing for the health insurance marketplace. DC Health Link was established in DCAS, but as of 2022, it uses technology that is operated completely separate by HBX. The essential elements of this collaboration and the nature of it is outlined in this rather clear graphic on page 9. When you get some time, you can walk through it. It'll show you how all these things connect. In 2021, we had a watershed moment when the district launched the District Direct website, mobile app, and integrated application as the final iteration of the 3 releases and the implementation of the ACA. Because of this very, very helpful addition to the system, beneficiaries, residents can connect to their existing accounts. They can see active cases. They can submit applications for food, cash, and medical benefits. They can recertify those benefits. They can provide change of circumstance as needed. They can view a personalized dashboard where they can manage and view their benefits. There's no more standing in long lines at 4 and 5 in the morning to access benefits as it happened in the past. Slide 11 illustrates how case processing has changed for residents. I won't go through all the details, but in the left side of the graph shows you what was used to be the old state, and the right side shows you sort of what had to happen on receiving electronic policies in real time. Processing eligibility determinations. The circle in this graph shows you what happens now. So as an example, if you look at submitting application documents online, under the old system, you had to submit an application or any required document in person or by mail. Now you can do it online. In terms of managing benefits, you had to go to a service center. You had to stand in line to get an update on your application status. You can now do that online through a dashboard. Those are just 2 examples. In terms of receiving electronic notices, although there have been hiccups in the system, in the old days, you had to wait to receive notices of eligibility determinations and other correspondences in the mail. Now you should be able to receive electronic notices in real time. When there are problems, we identify them. If there are system problems, we try to make the changes to correct the delivery of notices. Slide 12 basically summarizes the changes that have reduced the work of the caseworkers. Now, again, one of the challenges you hear about is just the growth in cases in general, but caseworkers have a much more efficient method that allows them to process cases, which is needed given the significant rise in caseloads since the time of the pandemic. In terms of funding, there's been a lot of discussion about what the system costs. It's a $622 million system over a 10-year period. Indeed, it probably costs more than the baseball stadium, but I would argue that it's more important than the baseball stadium. So I'm less concerned about that than I used to be when I used to chastise my staff for spending all this money. The cost allocation waivers that were referenced were critically important to our success in building this integrated system because it made enhanced funding available with different match rates across different programs. So we could have the same staff working on Medicaid, SNAP, TANF, development issues, and they would all get an enhanced rate based on federal rules about what the matching rates would be. That was very, very helpful. We are now, as been noted, moving into the systems development phase of the of DCAS. And so the bulk of what we hope to spend in 24 will fund major contracts such as operations and management and the call center. I will add the important caveat that because of the budget situation, the dollars that we have budgeted for 2024, over 97 million, are subject to change, of course, if spending pressures develop within and throughout the health cluster. To the right are a lot of the industry tools that we hope to incorporate and advance as DCAS priorities that we hope will stabilize and make the system more efficient. Tamika can tell you about some of what these things do if you have questions later. Councilmember, I would now like to move quickly on, as noted on slide 15, to the case processing. This is an issue that I know is of heightened interest to this committee. Although we are in the cauldron of Medicaid redeterminations, a challenge that DHS reports is exacerbated by the rise in SNAP and TANF caseloads, the team's work on Medicaid recertification, despite some of the concerns that were raised, some of them accurate, some of them not so accurate this morning, I think the team's work has been excellent. If you look at slide 16 and walk through the actual data, as opposed to focusing on, an anecdote that may be accurate or may not be accurate, you will see that for May through October overall, more than 3/4 of those whose recertifications are due, they've either enrolled or they are pending. If they are pending, we will not terminate their eligibility while the case is pending. I repeat, if they are pending, we will not terminate their eligibility. If that happens, then my staff will correct it. 80% or more of beneficiaries due in May, June, September, and October are renewed or pending. 70% or more for July and August are renewed or pending. There are lower rates in July and August, primarily because these are called PHE beneficiaries who were kept enrolled during the public health emergency, but had income or other changes that made them appear ineligible and therefore unlikely to renew passively. October includes PHE beneficiaries, but also many SSI beneficiaries whose benefits were automatically extended based on their receipt of SSI. For May through October, the potential disenrolled column or category includes approximately 10,000 non-disabled children under the age of 21 whose coverages were terminated or paused under a review while DSS and DHCF ensure their compliance with the ex parte rules for passive renewals. What all that means is you have a child in the house and a mother in the house. They have two different eligibility levels. We looked at the mother's eligibility level or the father's or both and said, okay, they are over the limit. and we terminated the household. That happened all over the country. CMS said, wait a minute, the child has a higher eligibility level than the parent, so you got to pick that up in the system. So what we did was we immediately paused that and we restored that eligibility. For October, it also includes approximately 1,200 people with disabilities and those age 65 plus who received 1 month extensions through November to allow additional response time. Earlier, non-MAGI extensions had expired. So on balance, while there are issues that we have to deal with on the Medicaid side, if you look at how the district compares nationally, I know Councilman White asked about how we look nationally. Well, here's an example. We are high relative to other states in terms of how we do Medicaid processing. We are in the top 10 for states who are renewing people or have people in pending status, and we rank 7th highest out of 45 states with data on the overall renewal rate. If you look at the rate of passive renewals, we rank 9th. Also, as this chart shows, one of the concerns would be terminations. DHCF data indicate that we have terminated about 19%. Now, most of those are probably going to be procedural terminations, but 19% compares much favorably to what you see across the country. Some states, the termination rates are well over 50%. So what about case processing? This is an area where we have some concern and we have to figure out how to deal with it. What you have in this chart on slide 18 are the average and median days it takes to process a case for non-passive renewals. Passive renewals are obviously rather easy. As you can see, and the median is probably more reliable as a measure of central tendency in this case because there are a lot of outliers in this data. So if you look at the median, the time that it took to process renewals as of September, the median for those whose cases were pending was 38 days. The average was 45. In terms of those where the cases were completed, the median was 13 days and the average was 19. Now, if you go fast forward to November of 2023, you can see those numbers have jumped a bit. For cases that are pending, the median number of days it's taken to process those cases, 60 days. The average is 72. And then on completed cases, those that were completed were done so in a median days of 18 and an average of 22. So when you dig into the nature of the pending renewals, and as you can see from the chart on slide 19, if you look at the number of people whose cases were pending from 0 to 30 days and from 61 to 90 days or 31 to 60 days, they're all captured by this pie chart. And what we know is that if you look at the people whose case processing has exceeded 60 days, that's about 50% of those with passive who are in the passive renewal category. So I asked my team to dig deeper on those who were over 65. I mean, who were over 60 days. Who are they in terms of their eligibility? Frankly, I was a bit surprised at the results. I thought most would be in long-term care because it's a much more difficult application process. But it turns out that 77% of those who have cases that are pending more than 60 days are Medicaid MAGI beneficiaries. Seems counterintuitive, but Melissa explained to me, and I assume she's right, that that when you have people who you would assume they could be passive renewed, you determine that they cannot, you say, okay, our data is showing that you have income here or you have something else here that makes you potentially ineligible. You have to submit information to show us that we are wrong. And so there's a process of transferring data back and forth that apparently is taking time. So of the 9,265 beneficiaries who are pending as of November 2023, 77% are MAGI, the other are non-MAGI. Slide 21 gives you a sense for this trend that we are concerned about and that we are watching. And these are new MAGI applications. If the data show, it should show 12%. Yes, mine shows 5%. So in August 23, those new Magi applications that took longer than 45 days to complete. And I believe that's the federal standard. That's the CMS set that standard. Yeah. 45 days to complete. We were at 12%. Move forward to September, we had 23%. Move forward to October, we had 38%. Move forward to November, that's 42%. That's a concern. And it is a concern because we are one of the lowest performing states in the country on this particular metric. So that is a concern. It is a concern, however, that is mitigated by the fact that we're not throwing people off insurance that they're pending. So hopefully, if we can lower the number of people whose cases are pending that we're working with, then we can more quickly get to those who have application period that's extending beyond 45 days. Now, we also, in terms of Medicaid still has something called retroactive eligibility. And so what we will do is once that person is determined eligible, we will look back to for a certain number of months or days to see if they acquired any medical expenses during that period that the Medicaid could pay for. But our goal obviously is not to rely on that. Our goal is to get this number down, and we have to work closer to do it. At this point, I'm going to turn to Director Zeilinger, and she can talk a little bit about the SNAP and TANF case processing issues and the process and flow that the process and flow that they use in DCAS.
Thank you. Morning, everyone. I'm going to just jump right in, following Deputy Mayor Turnage on case processing for SNAP and TANF. As you can see on this slide, we've had a tremendous increase in both the SNAP caseload as well as the TANF caseload. Our SNAP caseload has increased by 44,000 individuals when compared to pre-pandemic levels at the peak, and is currently increased from pre-pandemic levels by 37,000 individuals. Similarly, in TANF, our caseload has increased by 9,000 individuals. We know that with the pandemic, it put pressure on human service agencies because we became more reliant on safety net programs, and we are required to ensure that our residents have access to cash, food, and medical assistance. In order to meet this increased demand for services, increased need in our community, we have taken numerous measures to both improve our efficiencies as well as hiring staff. Especially in the last 2 years, we have a 17% increase in our eligibility staffing levels over pre-pandemic. This accounts for both the promotion as well as attrition. And so in spite of a 1-year attrition of 25% in 2021, our attrition has decreased, but we still only have a 17% increase in staff with about a 400% increase in tasks that need to be processed. So some of what we're hearing about the challenges that residents have, and as well as delays in our processing, come from sheer volume of workload, to which there are several solutions. On the next slide, I will walk you through a little bit about what does it take to process a case. We looked at data and numbers, and we understand the urgency that people have as they rely on us for benefits. And we thought it would be helpful to understand what exactly is entailed in that process and why it's not simple and fast, even with a very complex and modernized eligibility system. So as you've heard today, residents have 4 ways that they can apply for benefits in the district. They can apply on their phones through a mobile app. They can apply on a computer through the online portal. They may visit one of our service centers to complete or drop off an application, or they may mail an application to our service centers. Once we receive an application, we assign it to one of our SSRs, our eligibility workers, and it gets assigned based on the training and level of experience and expertise of the worker, depending on what it is that the resident is applying for. The application is reviewed based on the information provided, and we use a range of federal policies, which are different for every single program, that guide our practice, and we begin to process their case in the DCAS system. In addition to reviewing the information, we also then look into our document imaging system for the verification documents that are needed, such as income statements, proofs of residency, household information. Any information that may be missing or inconsistent in applications or incomplete then requires the eligibility worker to reach out to the resident to gather needed information. It also triggers a notice that gets sent to the household. The SSR will then complete an interview with the customer, asking for necessary information and clarification, confirms information in other sources that we use such as external databases to confirm and validate income. The SSR documents all information, including writing a narrative summary, which is required in our federal rules to summarize the case processing activities, and then authorizes benefits which are issued in terms of cash and food on an EBT card. Now, it's important that I spent some time on this slide because, as I noted, it's not a simple process. Cases must be processed accurately, and the rules are incredibly complex and variable based on a range of, again, federal rules and how they play out in different family configurations and household configurations. Once we receive a case, on average, we are reviewing it and beginning to work it within 15 days of it coming into our system. But many times, as the Deputy Mayor mentioned, delays happen as we're going back and forth in order to ensure that we are able to document all of the required information in a case. So an SSR cannot just open a case in DCAS, quickly check information and push a button in order to authorize benefits. For example, a brand new application for benefits takes on average 75 to 85 minutes to complete. A recertification would take on average 45 minutes, and a mid-cert, which is a much shorter form, takes on average 34 minutes. And that is the optimal path if all documents and if all information is consistent and all documents are present in the system. If they're not, that's when a case would go into a pending status. And when we look at the wait times or cases that are pending and how long they're pending, that number is an aggregate number that may include a delay on the part of the agency or a delay because we are waiting for information to be provided by the applicant. So I hope that again, information is helpful to you in understanding our processing. I'm going to move to the next slide in the next part of our presentation, which is just a quick summary of some of the challenges that we faced, and as well as our priorities to continue to improve going forward. We heard some testimony today, and I think the council is familiar that this was an absolutely complex system to build that many states shied away from. As we built the system to work through multiple releases, multiple programs, we needed to we had issues with our system integrator, but we changed vendors between various releases, and we navigated a whole range of fixes and upgrades in order to get the system functional through the development of a release 3, where we've seen major improvements. We also have overlapping eligibility processes, federal policies for SNAP and TANF and Medicaid, and they don't align. And so it requires applications that ask a lot of questions and a pretty long and cumbersome application for residents, something that in the next slide, I'll note what we're doing to try to streamline. And then application processing. So we've, as staff, are working in what was a brand new system. And then with many upgrades and improvements over time, it just requires training, retraining, and refreshing training as the system continues to change so that our staff are equipped to work in the system that we have. And there have been many changes through the course of the public health emergency that have changed policy, and every time that happens, again, it requires a complete retraining of staff. So and every time we bring staff out of working cases to do training, it can exacerbate what is sometimes delays because people are not processing at the time they're in training, although it's necessary. So as we think about what are our priorities and how do we move forward? So we have a very advanced modernized system and one that we're constantly working together to improve. So there's a number of enhancements that are planned and including a major upgrade to the Curum technology, which will be released is on schedule for summer 24. And in the meantime, every 8 to 10 weeks, DCAS releases additional technical fixes that are responding to errors that we see and are identified through different escalation paths as we notice issues with specific cases. So in addition to technology fixes and enhancements moving forward, there's also a huge effort to enhance the usability and customer service. So one of the DCAS's priorities has been to improve the user experience of the system, whether it's people who are logging in, residents logging in remotely, or staff on the eligibility side of the system. And one of the ways that we're doing that is through a partnership with Code for America, who's worked with a number of states. We were awarded funding to work with them, and they are helping us to streamline our application process, reduce the number of questions, and find ways that we can use technology in order to improve the customer experience, both from, again, the resident side and the case processor side. We are, DCAS is in the process of also procuring a new contract vendor to establish additional functions to make it easier for customers that can obtain information on their cases. In addition to improving usability, thirdly, there's a lot of work happening to improve the capacity of our caseworkers in benefit processing. So we're doing, as we see issues that come up that are caseworker errors, we are noting those and constantly modifying and redoing targeted training, simplifying workflows, and integrated help options within the system. We've also established multiple partnerships around enhancing system training, including even today, we have a group of staff who are trainers who are being trained in how to work with various adult learners so that the training that they're delivering is even better targeted to a range of different people who are constantly learning and relearning complicated policies and using the system. We're also investigating and are excited about the potential that contemporary technologies like AI have to further automate some of what happens that is a redundant task that our customer service representatives are required to complete for processing, like keying in information or dealing with return mail, which is a big issue as it relates to notices being returned to the agency. We have a $1 million 3-year grant that we were awarded to address forms and returned mail that we're excited for the potential of that. So I hope that that helps to explain some of the areas of focus for ways that we're continuing to improve our system. With that, I'll turn it back to Deputy Mayor Turnage for any final words, and then to members of the council for their questions.
Councilmember, my final words are simple. I'll just reiterate. I think the system, while very, very complicated, and must be consistently managed, is light years from where we used to be, and it is not perfect. When problems occur, we have to first distinguish between whether or not this is a systems error that requires a technical fix, or whether or not this is a caseworker issue. Those two things are sometimes difficult to determine initially, but we generally get there. I also would add, particularly to some of the persons who spoke about having problems with the system, there's an escalation system that DHS has with legal aid that I think they use fairly regularly. So it's not like something happens and there's nobody to talk to. I give people my personal phone number. If I get call, and we've already talked to our staff about the young lady who has, you know, a child with a very serious illness. She will not lose eligibility. We can just, you can cancel all your questions about that because we will make sure she does not lose eligibility. And we, Tamika already pulled up her case on the web. We see that there's no breaking coverage, and we will not allow there to be any breaking coverage. But I encourage people to call me. If he called me, I escalate it that day, regardless of what I'm doing. If the only time I don't escalate it in the moment is if I'm in a meeting with the mayor. And then as soon as I get out of that meeting, I escalate it. And I escalate it through my chief of staff and through our Medicaid director. So yeah, we know the system isn't perfect, but it is, again, much better than what we've ever had. And when we all finished and said and done, it'll be, in my judgment, the best system in the country. Thank you.
All right. Thank you, Deputy Mayor and Director Zeilinger. I have some questions. We'll do 10-minute rounds. Deputy Mayor, I'll say this at the offset. I appreciate the responsiveness of you and your staff when we raise particular cases and concerns. But in an ideal world, we wouldn't have to call the deputy mayor every time that there's an issue or escalate it to you, or for having residents know that you got to contact legal aid in order to get to the escalation piece, right? We want this to just work. And we know that there are issues that come up. So I'm going to start my questions on DCAS and then go from there. So you all discussed that one of the goals of DCAS was to make it so that application questions weren't repetitive. Yet we do have federal regulations that require us sometimes that many of the questions must be repeated time and time again. DCAS was also supposed to give automatic computer process determinations, but it seems as though some programs are still receiving review by a human. So while we had great intentions in theory at the offset of this, would you say that the practical realities aren't allowing for DCAS to work to its fullest potential?
I would modify that statement to say that there are no system can be designed to account for every possible circumstance that you're going to face. It's not going to happen. So what the challenge then is, do you have a flexible enough process that when those bumps in the road are identified, can you fix them and fix them expeditiously? I think we are at a point where we still don't know what all the bumps in the roads are, and we still are working on the process to make sure that we fix things expeditiously.
Okay.
But that's where I believe we are. Yes.
Okay.
And I'll just if I could, because DCAS works through a number of different, we use DCAS for all of our eligibility programs. There's no system anywhere in the country, nor would I would push back to say that it was envisioned that the information goes into a computer and the computer spits out an accurate eligibility determination. There's always been, and there is everywhere else in the nation, a requirement for an eligibility worker to put eyes on that case and to verify information. And the rules and the questions are so nuanced and so complex that there are often inconsistencies within an application that require a further interview. And before we had waivers for some interviews, which are temporary now, the application process often requires an interview with an applicant at the time of application and recertification.
Okay. Well, Director, let me ask you this. So in the testimony or the presentation rather, Deputy Mayor, you said what makes DC different than several other states is that we can make real-time determinations. Mm-hmm. What's the definition of real time, or which program are we able to do real time for? Because the director just talked about everybody has to get a touch, and then in most cases we have to do an interview. So what are we real time determining? I would define real time, and Tamika can jump in, is once information is submitted to the system, there's a process that requires a very brief process that requires the caseworkers to make sure that documentation is there. Once that documentation is processed in the system, an eligibility determination is made. Now, there are things that can happen that would slow that down, and Tamika can speak to it, but that's how I'll define real time, as opposed to you handing me
a stack of documents. Then I have to sit through and say, okay, how does her income compare to the standard? How does, what should her benefit be based on her household size? That's all computerized. And so as long as you give the computer the right information, it will make a right determination, and it can do it in real time. Tamika, you want to add to that?
Thank you. Yes, and I'll add, particularly with Medicaid, streamline Medicaid, we can get a real-time eligibility determination as long as all the information is present and it matches what our data hubs has also, that we receive from our data hubs. So particularly real-time, when we talk about eligibility, is for Medicaid, Magi Medicaid.
Okay.
Anything other than that for the other particular programs, as the both directors were saying, is the system will collect the information and put it in a dashboard that can be easily seen and understood for the caseworkers to review and process the case.
Right. Okay. So I guess with terminology, because when I think of real time, it's I hit submit, and then after a certain period of time in that same day, you were telling me, hey, you're eligible.
And that's true for Medicaid. That's true for Magi.
So you're saying for Magi Medicaid, yes. For other programs, no. All right. So that's good to know.
But still, for the other programs, and Laura can correct me if I'm wrong, that information goes to a dashboard, the caseworker touches it, eligibility determination is made. That's very different than what we used to have. Very different.
So with
Right, but still on the definition of real time, Laura, you said, what is it? At least we get to every application within our system within 15 days of it being completed.
That's because of it being submitted.
Right.
Right. So for example, before the pandemic, when residents were coming into service centers, we were sitting with them and processing every case that we could possibly process, start to finish, and doing real time eligibility with people in front of us.
While they're sitting there.
Okay. We shifted during the pandemic. We both had waivers for interviews and to reviewing documents and calling customers when there is questions or information needed, and they're not sitting in front of us. It's a longer process and it requires more back and forth. We will return to, as people are coming in, to be able to doing that one-touch processing, but that requires oftentimes somebody there with their documents or documents that are retrievable while they're sitting with a caseworker, and that reduces the number of times people are coming back to our service centers and calling. But it's not that it's not. So it is possible, and we do have a history of doing real-time case processing and eligibility determinations. But I think the thing I'm wanting you to appreciate is the big shift is not only just the efficiency of the system we have, but the reality of the number of people who are on benefits, such as SNAP, who are not. That's a lot of 44% is a very sizable increase in the number of residents in that program alone.
Okay.
And I would add, just on the Medicaid side, from the time we started the renewal process, which was April to the end of October, we've looked at the system has processed over 156,000 cases. About 70% of those, I believe, are passively renewed. That means automatic.
Right.
So
on Medicaid. I know.
Yeah,
we're talking about lots of different programs, right? All the various programs here. And I can appreciate all of the number of people who have been passively renewed. Those aren't the people who call our office, right? And it's not I can't just say, well, we're doing great with the 77%. So sorry, you're not in that.
No, I understand.
Group of
those cases tend to be inherently more complicated, and sometimes sometimes it's a staff problem,
right?
And we found out that staff didn't do what they were supposed to do.
Okay, so let me ask you a couple of really quick questions in my 2 minutes here. So, who are the key vendors that we use for DCAS development and maintenance? We don't do it all in house. Who are we paying?
Right now, primarily our staff is in-house contractors. We also have and we have our contracting staff. We have E-Systems, who we contract to do some of our application development, and we have Diona, who's also supporting and doing that development and maintenance for our mobile application.
Diona? Okay. So when Director Zeilinger talked about some of the things that the new enhancements to roll out in summer, who are working on those enhancements? In-house or vendor?
All of my staff. So they're all considered I consider them all in-house, but they're all the staff under myself and DCAS. And so they can come from various vendors, or they can be individual contracts with the resource.
When do we switch to having more in-house contractors doing the work versus an outside vendor?
We've always had that. So there's always been a distinction between development and O&M. O&M has traditionally been in-house staff augmentation contractors, and the development side has traditionally been the vendors, where, for example, release 3, we had KPMG. Prior to that, some of the other releases that we're talking about, IPS and other vendors, they were doing focusing on the new development while our in-house staff was maintaining it.
Okay. And the amount of money that we spend, I think 97 million for this year, how does that compare to other states who have a similar system?
I think is comparable, but we would have to go and research more to do, to get the actual numbers of what they're doing. I have not done that particular research, but we can. However, in discussions and kind of meetings and conferences with other states, we seem to be on par.
Okay, thank you. Chair White.
Thank you. Deputy Mayor, I'm listening to your testimony and I'm wondering why we're even having a hearing, because it sounds like your sense of things is that our system is pretty good, better than other people's. But as I'm listening to the details, I'm hearing a resident, Ms. Pelham, you just said in response to Councilmember Henderson, her child won't lose eligibility. She came to testify that she needs assistance that she can't get because she's waiting on something to happen through our agencies, and that's not happening. So the notion that her child is harmless in this is not accurate.
Well, wait a minute, you putting words in my mouth now. I didn't say that her child had not been harmed. I don't know if her child has been harmed. What I said was we would not let her child lose eligibility.
Right.
We won't.
Okay, but so that's not her point, though.
Well, I'm not talking. I'm just talking about what I said. That's what I said.
Right.
Right.
I understand what you said.
Correct.
What I'm suggesting is that is aside the point. And so I think you might be missing the point. So looking at the slides, you're comparing the old system to where we are now. Slide 11 says, with our current system, no manual caseworker process is required. But we kept hearing from witnesses who said they got to call somebody and they have trouble reaching someone. So that's not accurate. It says information is automatically sent and received electronically. We had a witness who said they got to show up to the office to submit things. So that's not accurate. Your testimony, I think slide 20 said no one loses coverage in pending status. That's not what people testified to us. So how do I reconcile this disconnect?
Well, I think you have to listen to the facts. The facts are that we have a system that allows you to submit information by phone, by portal, or you can come in person. That is your choice. We don't restrict your choices. So some people choose to come in. They're more comfortable handing their application to somebody. We're fine with that. That's not a problem. If you are on Medicaid and you are pending, we do not terminate your case. So you are still getting coverage. If there is a problem, and problems can develop in the most perfect of systems. If there is a problem, you bring it to our attention. I will make sure that that problem is fixed and any bill that you may have received is paid. Those are the facts.
So to Ms. Pelham, given the facts that you laid out, what would you say to her? What should she have been doing for the past 2 months with respect to her child and the services her child needs?
I don't have recall of what her case was. What I said was she's not going to lose coverage. So I need to know. I don't have the details of what precisely she's struggling with. It seems very complicated. But what I gleaned from it was she needs to get her child into Katie Beckett, which is a different process, requires a different application. And all I'm saying is we will make sure that when that happens, or when that process is initiated, we will make sure that before, I think she said end of February, we'll make sure that that process is complete without her child losing coverage.
All right. So what her
But I-
child
but
needs
I would
is
also-
speech therapy and mobility therapy.
Right.
And what she is suggesting is at age 2, every day, every month that goes by, there's less of a chance for a child recovering from these because treatment is necessary early and immediately. So what could she have been doing differently over these past 2 months?
Again, I don't have the details of precisely what she did, but what I would say and is that if there is a challenge with getting services, I tell people, call me directly and I'll fix it. Just call me directly. I do it all the time.
Which is, to me, a symptom of a very broken system.
Well,
If you have to go to the top of the system
but
and
I
get things to
disagree.
work, the system
I
is
disagree on
broken.
this point.
And we're here because the system is broken.
The system is not broken. We process 156,000 cases for Medicaid. 69% have coverage. 72% of those 156,000 cases were renewed passively. That all takes significant technology. We have to speak to a data hub. We have to compare income. That's done at the snap of a finger. That system is not broken. Yeah, there are problems. We have a lot of cases. We have caseworkers that sometimes struggle with the new system. Those things have to be addressed. But to characterize the system as broken is fundamentally flawed and inaccurate. The
It's
system is
not.
broken.
If you have to reach the top person in order to get things to work, the system is broken.
Now,
There's no other way to see
we
it.
would just agree to disagree.
What about SNAP error rates? What's the SNAP error rate?
They are a problem.
What is the SNAP error rate?
There's, in fiscal year 23, our error rate was 16.89%.
1616?
16.89, so that's 17%.
Which means 84% of the cases were not inadequate.
All right, we are looking at,
Do one of you have a phone on
I think it
the
is.
table?
My phone.
In 2022, the district reported the nation's highest error rate at 80.46%. With the slowest SNAP processing time in the country. You're suggesting that that's not accurate?
No, I gave you the rate for fiscal year 23.
Okay. Fiscal year 23.
If I could explain the error rate, there's 3 reasons why we would have a case would fall within a SNAP payment error rate. There's wages and salaries, so a disconnect between how wages and salaries were treated. This is where a client may have reported information, then when you go into the verification system, there's a mismatch. And so when that case is audited, there's a mismatch between what the client reported and what was verified in an information system. When we look at our payment error rate, it does not distinguish between a worker error and an error caused by information that a resident submitted. In the area of wages and salaries, the client caused errors make up 59% of our errors. The next area where we have a significant number of errors that make up our SNAP payment error rate is household composition. This is where there may be someone within the household who is or is not reported in the SNAP case. The number of client errors, and then that when you go into a verification or an audit, are in household composition are 88.4%.
Okay.
The third aspect of the payment error rate is shelter deduction. So calculating how much is somebody's housing cost compared to what it is that they reported, and then accurately reflecting that in how that impacts what they're eligible for in SNAP. This is one where we are very focused because the agency error in how we accounted for their shelter deductions was 91% of the time. That was a DHS caused error. So again, the wages and salaries are number one cause of SNAP payment error rate. Household composition is number two. Shelter deductions are number three.
Got it. So here's the point, and I want to go back in calendar year 22, the error rate was 80.46%. You responded in fiscal years. The error rates, what I'm hearing from your testimony is that the majority of the errors are user errors. But if users are erroring the majority of the time, the system isn't working for them.
So there's so we have a corrective action plan with the federal, with FNS, with the Food and Nutrition Service, which is the federal agency that is responsible for the administration of SNAP. We have identified the specific actions. Some of them are system. I don't know when you say system, if you mean technology or the overall system that we are a part of in terms of everything from how a worker interacts with the case and their training to what the actual DCAS system does. Some of it, I'm going to differ you when I say system, I'm going to talk about the technology. Okay. So not all of that is the system. So if you look at our corrective action plan, which is very detailed with a whole range of actions, a number of them complete, some of them pending, there are both system related fixes as well as retraining and other non-system related issues that are part of an agreed upon approved corrective action plan to get to the root of what what is happening and how to fix it. But it is, I just want to encourage the council to not simplify this as this is the system that is not working. We do have a problem. You do not hear me saying we do not have a problem, but it's not, if it was simple, we wouldn't be sitting here.
Right. But if we don't acknowledge how significant the problem is, we won't fix it. And that's my concern in the hearing, is that there doesn't seem to be an understanding from the administration how deep the problem is, including the fact that if user errors account for this much, then there is still a problem in the system.
I would say the administration fully understands what we're doing with DCAS, what the locus of the problem is. And when we identify those problems, we work on them assiduously. The administration is not walking around with their head stuck in the ground. We work on DCAS every day, whether it's a system problem, a caseworker problem, or a user problem. But I will say in all of that, this system delivers eligibility processing much, much better than anything this city has ever seen.
All right, so you're fixing problems as they arise. So this 59% client error rate in SNAP, what are you doing to fix that?
So I would ask you to refer to them, or I can certainly reshare with you, sir, that AWL, our advanced warning letter, corrective action plan, and all of the things that we're doing to improve our administration, the SNAP program. Some of it is has to do with how we verify income and our access to the work number system when users are checking that system, and as well as on the back end when those cases are reviewed. There are certain things in the process of how that happens, as well as improving access to the data systems to understand the difference between what a client reports and what a verification system says, which still requires us to go back and address the discrepancy with the applicant before we make an eligibility determination.
I'm over time. I'll have questions on the next panel. Thank you.
Thank you. Councilmember Parker.
Yes, I'll pick up there. What is the average processing time for SNAP benefits? And while you look that up, it is my understanding that we have the slowest processing time in the country. And if you could just confirm if that's accurate.
So we do, SNAP timeliness of processing in SNAP is absolutely a problem. And we, while I'm happy to say that our performance is improving, that we are absolutely not where we need to be. And at one point we were the slowest in the country. That is accurate. I think it's also important to understand the workload pressures that our staff are under, that we have 400% more tasks to process in a day with 17% more people. And so that requires us to work very differently as it relates to people, processes, and systems. And it's not a unilateral,
Understood.
simple solution.
Yeah, I take my hat off to DHS. I am very clear-eyed about how complex the work that you all have to do. At the same time, what I heard from my colleague, Councilmember White, is that on the other side of these very real issues are people's lives hanging in the balance in many respects. And I know that's not what you want, but that's the reality. Do you have that number?
Yeah.
And if not, if you could follow up with it.
You're asking how long does it take?
Yeah, like the average processing time.
It varies. It's just going to be, I would rather get back to you with.
Well, let me ask it this way. Is there a target processing time for SNAP benefits? So someone comes in and applies, how long should it?
So it should take, expedited is 7 days, and and then we still need to do the full application eligibility, for which we have 30 days.
Okay. I have some other questions. I wanted to go more in Medicaid direction, but while we're here, there were also, because of the real constraints on the agency, the council allotted staff in this last budget process.
Mm-hmm.
Do you have an update where we are with hiring folks to help with the uptick in SNAP benefits?
We've onboarded 136 SSRs in fiscal year 23 and 24. I think it's important to recognize that given the complexity of the programs, that people need to be trained in policy and systems for every single program separately, SNAP, TANF, Medicaid, that it takes at least 6 months from the time of onboarding to when someone is able to work on a case, and then additional time before they are able to authorize a case without a second review.
And so is it safe to assume we're in that 6-month window of you all trying to?
So we have hired about 10 cohorts. We have an additional cohort coming on of additional 22 staff that we're in the process of hiring, but we also have had attrition that has slowed, but it is a process. We're seeing that we do have more workers processing. We also received a waiver recently from FNS, and while it is required that a full-time employee cannot process SNAP, there are certain activities that they have required that it be an employee, where we have a waiver to use contractors. So we're partnering with DHCF to add to our call center contract additional staff who can help manage phones and inquiries about cases, so that we can move more eligibility staff to case processing. And we look forward to having that in the coming weeks.
Okay. And of those 22 new hires, how many would you say are dedicated for SNAP process?
So we train all of our eligibility staff in every single program, so that, because the goal is with an integrated system, that there is an integrated experience where they are working with
So
somebody.
theoretically, they could, if needed, help with the processing of benefits.
Correct. So we have at times trained people only in SNAP and put them on SNAP only workflows before they've received their other training. So to deal with where we have high workload pressures.
Okay. And I imagine my colleagues will get at this, and I do want to just pivot because I have some other questions, but the elephant in the room is that the council also allotted money to give SNAP a raise or increase people's SNAP benefits. I will tell you, there are many residents that are excited and looking forward to that. And the council received word that the administration, the executive, the mayor's office is not planning to follow through on that. very simply, what communication or outreach is the agency planning to kind of give people an update that may be anticipating an increase in benefits in January, if any?
I think once that decision is made, it would be articulated through my office to DHS, and any necessary communication would be executed. Right now, it is in flux because of the significant challenges in the budget for 24 and 25 that they are working on almost 24/7 as we speak. There are over $800 million in pressures in 24 that they have to figure out how they're going to pay for. And until they figure that out, they have to hold in abeyance any plans to take on another $35 million local expenditure in 25.
One hand, that makes a lot of sense, and I'm sensitive to the pressures. On the other hand, that money was allocated. It's not that it's just up for grabs. We allocated it to give people a boost to their SNAP benefits.
Sure.
Data tells us people that are receiving SNAP are exhausting those benefits in the first 2 weeks of the month. It's because of that we increase the benefits. And so while I know this isn't the intention, it just seems like, oh, you know, we're going to just swipe this money. And again, on the other end of that are very real people living in the balance that I just would love if we could show a little bit more care and concern about. And
I don't think there's any, I wouldn't interpret the administration being fiscally prudent and trying to make sure that we do not violate federal rules about deficit spending as being uncaring. What the administration is being is precisely caring, not only about the benefit packages that we have to honor, but also about the fiscal responsibility that we have to show. If we did not, then we'd have much bigger problems.
I want to pivot. I would just say when we're talking about people having access to food and being able to feed their families, and we're juxtaposing that with a lot of talk about a football stadium. We're talking about millions of dollars in other investments to the city that are important. It just begs the question, why are we going for the SNAP benefits? And it just, for me, I suspect it's because of the people who are receiving SNAP benefits.
I disagree, and I would say,
and I hope I'm wrong on that.
Yeah, you are wrong. I would say respectfully, Councilwoman, you are wrong. The notion that I got $800 million that I have to figure out how I got it. So I'm going to hold in abeyance any new major spending, regardless of the source, until we figure this out. Does not mean you're targeting anything other than new spending.
If you're open to it, I would be willing to provide recommendations where we can start pulling money so that we can get to 800 million.
Yeah.
While still making sure we give people a boost to their SNAP benefits, because I think both can be true. We need to fill this gap, but we also need to make sure people can eat.
Well, I'm neither the budget director or the CA, I'm sure they will welcome your recommendation.
I will follow up on that. And in fact, if maybe as a committee, we can make those recommendations because it is a big priority for this council.
Sure.
In my last minute, and I know I'm running short on time, I wanted to come back to the 16 out of 18 case management organizations that are not in compliance, and maybe that's not the right term. We heard from advocates that they are recommending that we do away with partnering with them. And it seems like your focus is on training. Can you just justify that, and what criteria, if any, is being used to maintain those case management organizations that are not in compliance?
Sure, I'll do my best. And if I need to follow up with additional information, I will. So the case management is available to individuals in our elderly and persons with disabilities waiver. I think that's the main reference point. So it's a program of about 5,500 people. Every month we have about 400 to 500 people on average who are renewing. And we're seeing just about 50 of those individuals, 50 to 60 are having zero response to a renewal. So from my mindset, that's not the majority, right? And so my preference is to work through whatever issues we're seeing and resolve them for the good so that we can keep going forward.
But you all internally have flagged that these 16 organizations are not
Yeah, so
meeting
what
your
we-
expectations.
Sure. At the very beginning of the renewal period, when we sent our first 90-day notices to folks on the waiver, and I started to see the response rates, they were not acceptable by any means. And I met with the case management agencies and let them know that they weren't meeting expectations and that we would be monitoring them and doing our oversight responsibilities, which is what we're doing. We know, person by person at each case management agency, has the case management agency reached out to the individual? Have they requested there's a lot of steps, the physician order form? Have they gotten the correct information? Our staff meet with case management agencies twice a week to go over these cases to make sure they're tracking. We give them notice right at the 90-day mark that here's your next pool of folks. Here's the status. So we've increased our information sharing throughout the renewal process. And it's through this process and our heightened oversight that we have a really clear sense of who is and is not performing and working through those issues. So yes, we've done training, because when we see something not working right, I don't think it's right to say the whole thing's not working right. Let's try to fix those issues, because we do have some case management agencies that perform well, and we're seeing improvement overall.
Okay, thank you.
You're welcome.
Thank you. Ms. Fitzgerald, when you all are rolling out new updates on any of the DCAS or district direct systems, are there user testing?
We do have user testing, and I'll preface that by saying when we do user acceptance testing, that's with our caseworkers in-house. But if you're talking about from a public standpoint, we have not done that with our last major implementation because we were in the pandemic, but we usually would.
But I thought the last major update would have been a mobile app. So why would you not be able to do that during the pandemic? If we are pushing out a beta linked to a group of people saying, hey, can you try to do X and tell us your feedback, why couldn't we have deployed that?
Well, maybe we should have, and we will do that moving forward as we are working on making the corrections and making the updates to our mobile and district direct online based on a lot of feedback that we've been receiving.
Okay, so for the next rollout that's coming in summer of 24, we're gonna test with real regular people.
No, summer of, can you tell me what you're talking about for summer of 24?
I think that Director Zeilinger said that there's an update coming in 24 to address some of the issues that were cited. Is that not accurate? Enhance usability and customer service.
For the upgrade.
Yeah.
Depending, yes, if there's parts of the upgrade that the users that impact the user community, then yes, we will definitely work.
See, I feel like this is an opportunity to just, since we've never done it, to test what's working, what's not. Because we heard testimony from folks today saying, I needed to update my address and I couldn't, or I needed to do X and I couldn't. And what I'm thinking is happening in terms of some of the error rates is similar to what was happening with the Department of Employment Services unemployment system. People got frustrated that they couldn't do what they wanted to do in that system, and then they would open up a brand new application, start all over, and then they get flagged for fraud, or at least that was happening in the unemployment system, because now it's showing that you're applying twice for benefits. And I'm imagining some of this error rate is duplicates in the system.
Yes, we will do that. We are working and partnering, as we talked about, with Code for America to put some of these groups together, to put focus groups together, to get surveys out there so that we can get this input.
Okay.
So yes.
All right. So we'll follow up on that during performance oversight to see where we are in terms of that particular plan. Director Zeilinger, I want to get some clarity, especially while Councilmember Parker is still here, because again, one of the goals for this hearing is trying to figure out, is it a system problem? We know there are problems in the system, or is this a people problem and a resources on the people's side of things? Okay, so you told Councilmember Parker that in FY23 and FY24, you onboarded 131 SSRs. Did I get that number right? Okay. 2 months ago, DHS reported to the committee that you have an average of 181 social service representatives who process applications for SNAP, TANF, and Medicaid. and that there were 22 vacancies for those positions. So if I'm doing back of the envelope calculation, if you've onboarded 131 people and you have 181, are you telling me that 75% of your SSR workforce is less than a year old?
No, so that's the number of people who are processing applications on average at a given time. So we have some people who are working call center, because as I said, until we got this waiver and until we have the contract in place and operative, people who are doing call center functions, picking up calls, answering questions about benefits, processing in the call center, also SSRs.
Okay,
We
so
have
how many?
SSR, we have more than 186 SSRs. We have 186 people who are not on vacation, not in training, not working the call center, or one of the other activities related to benefit processing, doing eligibility at a given time.
Okay, so I think that must have been a miscommunication, because my questions specifically, or my latest questions in that letter specifically came out of a Medicaid hearing. We were talking about who is processing Medicaid applications. And so I was assuming that the 181 didn't include people at the call center, because my understanding is they cannot process.
Right, it doesn't include people at the call center.
Okay, so how many people?
But we still have to staff a call center.
True. How many
Yes.
people process applications?
So right now, on average, at any given time, we have 186 people processing applications.
Okay, so the council provided 18 new positions in the FY24 budget. What happened with those 18 positions?
So we have hired and are hiring positions all the way up to our FT authority and funding. And people are coming on, being trained over the course of on average 6 months, and then working in a range of functions in eligibility.
Okay. How many vacancies do you have? I'm just trying to get to, like, do you need more people? And I don't know if you could say that out loud, but that's what I'm trying to get to. Do you need more people?
More people would certainly more people given the workload pressure. So what the increase in people has resulted in is 17% more people processing, with a 40% increase in our caseload in SNAP alone.
Okay.
So I think you can understand the mismatch between human capacity and workload pressures.
Right. So let's actually back out of this. So like I said, this is the third Medicaid related hearing, but we've talked about it at performance. We talked about it at budget. And I keep asking Director Turnish, I kept asking, do you guys have enough people? Do we have a plan? So we already knew that our numbers of SNAP were going up. We knew that our numbers of TANF were coming up, because I think SNAP renewals also restarted this year. And then we have this influx of new Medicaid folks who we're also going to have to renew. Why didn't we add any more staff?
We have added staff. I think I just explained to you how many people we've hired.
I know, but 400% increase of cases versus 17% increase in staff. That's a mismatch. You said that. So, I mean, let me ask this. Are there enough SSRs to chip away at the backlog of pending renewals to get us to the required timelines?
So I don't think it's only a person issue. It is, we're continuing to create better efficiencies, improving usability of our systems. We need to create more streamlined processes and procedures, improve our training so that it takes less time to complete a case, and we need more people. So it's all of the above. There is not one singular solution. And I think we have a lot of potential with some contemporary technologies to really reduce the amount of steps that a caseworker has to take.
I understand that. I guess I'm concerned. Here's where my level of concern is. It's December of 23. We're at 18,000 pending Medicaid applications. We have all of these other pending SNAP applications, and we're about to start this process all over again in a few months. Can DCAS system differentiate between if somebody applied in 23 versus a renewal application of 24?
Somebody applied in 23.
Like, I feel like we're gonna get to a place where someone who has submitted their stuff in 23 might not have a determination by the time they have to resubmit it in 24.
Well, if they're at the tail end of the process, yeah, but the system is more than capable of picking up a duplicate application.
Okay, so there are 728 people who are still pending from May.
Right.
Are we gonna approve them before next May?
I know, but they still get insurance. They're
I understand that. What I'm
Right.
saying is, in theory, the system is supposed to work where people have the continuous coverage once you submit the stuff. We know that's not happening 100% of the time. Folks are getting dropped. Or they're going to a pharmacy and they're finding out that you don't have paperwork.
If
We've had
that-
people testify, legal aid, et cetera.
Yeah, I don't, that is far from the norm. I mean, we don't interrupt coverage for people who are pending.
I understand, but also when I'm thinking to myself, though, you may not interrupt coverage, but the staff on the other end who are already staring down I'm not going to use barrel because that's weird, but like the tunnel
Right.
of a very high pending rate. And that pending rate is just going to keep getting higher in a few months because these folks are going to be coming right back to
Our pending rate is not an outlier for the rest of the country. You look at data as of November 21.
I know, but I don't want to be like Florida. I want to be better than Florida.
We're in the top 10, we're in top 5. 14%. This is, look, but y'all, let me give you some numbers so you can hopefully appreciate what the system was faced with. Before the pandemic, the maximum number of people in Medicaid was about 250,000. After the pandemic, during the pandemic and after, it hit 305,000. That many people had never been on Medicaid before. Now, a substantial number of those people, could be ineligible because we stopped doing eligibility checks as mandated by the federal government during the pandemic. So if you look at the difference between 305 and 250, and our caseloads typically increase 1 or 2% each year before the pandemic. So you're talking about an 18% jump from 250 to 305. If you look at our termination rate as of November, it's about 19%. That's sort of kind of in line with what people are thinking about. Well, some of those people are probably legitimately not eligible. And the reason they didn't respond if they were potentially passive is that they know they make too much money now, or they moved to another state. So then you look at pending, we're at 14%. With those kinds of shifting numbers, you're going to see, some cases pin. Now,
I understand. When you use percentage, though, I think it kind of masks how many actual cases we're talking about under that.
Yeah, I mean, the percentage is used to control for, changes in size and
Understood.
population.
But I'm thinking about it from let's say we have 6,900 of these applications that are pending. I think that's right. Or a particular number that might be around the right thing. Over 60 days, 6,900, that's over 60 days. When we add to all the other numbers from TANF and SNAP of the applications and cases that we're seeing, and we have on average 181 to 186 people who are reviewing this, and I didn't even get to how many tasks in a day that someone does. Are we ever going to get to a place where we are caught up? Is my question.
Without a bump in staff is what you're asking.
Correct.
Yeah. I have to go back and look at the numbers to think through that. Clearly, if you haven't.
Unless we're doing some extraordinary overtime, which I don't see that happening.
Right.
Or you're increasing staff, or you're detailing people, or you're doing something, we are going to be trickling along for the foreseeable future based on the current rates of processing. But I'm well over my time. Councilmember White.
Thank you. The slide 22 indicates, and this has been a subject in multiple conversations with council members, that the number of people enrolled in SNAP has increased by almost 40,000 since 2019. Why is this?
Based on their income eligibility for the program, people need the resource. And I think it also is a testament to the accessibility, improvement in accessibility of the program through the mobile app, online processing. So people have more ways that who qualify, who can apply.
And so, Deputy Mayor, I learned recently that the administration is not planning to implement the Give, Snap, or Raise Amendment Act. That is the law. Is that correct?
As I stated earlier, the administration has put those decisions on hold until they can figure out, from a budget standpoint, whether they can pay for it.
Okay. So at this time, the administration is not planning to implement Give, Snap, or Raise.
No, that's not what I said. I said they put the decision on hold as they look at the totality of the global budget in terms of pressures that are presently unmet.
When would that money start going out the door if it was not on hold?
Well, I can't answer that question right now because I don't know when the decision will be made to either not do this or do it. But clearly, given the original time periods for Give, Snap, or Raise, we're beyond meeting those, given what you have to do to get to stand up the program.
What would that entail?
Well, there will be some changes to DCAS that you got to hire a contractor. That contractor has to have the rules provided to him by DHS on what the new thresholds for payments will be. Those rules have to be coded into the system and then tested and executed. So we're talking from the time of procurement to execution, you're probably looking at, and we probably have to do it on an emergency procurement if you did it, you're probably looking at 3 to 4 months.
So if the council passed a law that indicated that with a certain trigger that's been met, we're going to do additional SNAP benefits, this would affect approximately 140,000 district residents. What's the open question? Why is there ambiguity for the administration as to whether or not the administration needs to follow through with this?
Can we pay for it?
And that's an open question right now.
That's an open question. Yes.
Okay.
You got Metro needing $300 million just to keep the lights on from DC. You have labor contracts that will cost probably about $400 million retroactively. It's close to 800 million that we have to figure out how to pay for in 2024. So the question is, once you figure that out,
close to 400 million,
800 million.
800 million.
Yes.
Okay. And that's Metro, and what else? Major costs?
You got labor costs. Union contracts have to be resolved.
What labor costs?
I'm sorry, I can hear you.
What labor costs?
Labor contracts.
Labor contracts. Okay. So Metro and labor contracts.
Now, let me caveat all this, but then you dragged me outside of my area of expertise here. So these are global budget questions that people are much more qualified to answer than I am, but that's the general position that we're in.
What about within the health cluster? What are the major?
Oh, there are lots of pressures in the health cluster. Okay. I can tell you right now, and maybe I'm speaking out of school, but I'm gonna do it anyway. We are looking at to hit a budget target in DHCF in 25 based on anticipated utilization. That means growth in spending due to enrollment increases or the cost of the benefit, given all the stuff that we do. You're talking about it was about like $142 million in local, more than what we think we can get. So you do a total computer on 142 million, that's probably $400 or $500 million in total Medicaid spending. In 24, the number, I think it's 40 million. I don't have a precise number from. So those, and then that's before you get to the pressures in DHS, which Laura can detail, which are significant. So it's not as if there's a pot of money sitting out there and we're deciding, we don't want to do Give, Snap, or Raise. There are ongoing obligations that we have to figure out how we're going to pay for.
And so Medicaid, this significant increase is because of an additional number of people in the program?
It's due to a number of things. Mostly it's due to the growing cost of the benefit.
Okay.
And we also factor in enrollment increases. But we model all that stuff out. So you have the cost of the benefit, you have provider rate increase costs, you have enrollment costs. Those are the three things that drive Medicaid spending. If you ever want to change Medicaid spending, you're either gonna have to cut people from the program, cut benefits from the program, or cut the rate you pay providers.
Okay.
Those are the only three things that will get you any real money in Medicaid.
How are the provider rates determined?
Well, it depends on the provider group. It's very sophisticated methodology that we use for most of them. We look at.
Is it negotiated or is it something that's?
Well, we look at, there's always an element of negotiation, but we have to be true to what, the data we have on costs are saying. Our biggest costs, the health plans, they negotiate with the providers. We give them a certain amount of money, they negotiate. But in negotiation, they have to be attuned to where our healthcare costs going.
These are negotiated annually?
Oh, yes. Yeah, they negotiate annually. The rates for managed care plans are certified each year with CMS. They have to be actuarially sound, or CMS will not approve it. And then the district would be on the hook for 70% of over $2 billion.
And the cost of benefits, it's
increasing.
But that's not negotiated, is it?
No, that's when somebody goes to the doctor and it could be two things drive benefit costs is how much you utilize it and what the unit cost is.
Provider costs and cost of benefits, those always go up, right?
Well, healthcare inflation.
They don't go down.
I've never seen a year with healthcare inflation. I've seen it where it's close to flat, but I've never seen it drop below what it was the previous year.
Okay,
never.
So how did you all bake those anticipated increases?
We have
into
a very
future budgets?
we have a very sophisticated modeling process that we use that basically says, okay, this is what you can expect in enrollment. This is what you can expect in benefit costs. This will be our total need. Now, we do that irrespective of what the financial forecast is. So we can say our total need is going to be $4 billion, and the financial forecast said, well, I don't know where you're gonna get the money from because the forecast is dropping.
So if there's a hole in the budget, then does that mean that your estimation broke down?
No, our estimation is based on the historical figures in the Medicaid program. So we tell the budget office, this is what you can expect to see in enrollment, absent any change in policy. This is what you can expect to see in benefit costs, absent any change in policy.
Okay.
And so when they go through budget formulation, they have to decide, are we going to accept that and pay it? Or are we going to tell DHCF, you got to figure out something different because we're not going to pay that. And that's what we're going through now.
Okay. Now, what about prior to that? Did they accept the agency's projected increase in cost?
I will say that we are, in terms of total funds, we are the largest funded agency in the district. In terms of local funds, we're the second largest to education. The administration has been very true to their position on healthcare being a right. And so when they give us these substantial targets that we have to hit, when we show them the only way we can get there, typically they said, okay, we're going to give you some of that back. Now, that's when they have the money. If they don't have the money, they can't give it back. They're going to have to tell you, well, you got to take that hit. But we're not there yet.
Right. So I guess where I'm going with this.
And the other piece is Medicaid is an entitlement program. We, as an agreement with the federal government to participate, they don't allow us to arbitrarily change eligibility rules and deny people below the levels that federal government require to be covered. They also have a prescribed set of mandatory benefits that if you're going to participate in the program, you have to pay.
So this is my concern I'm getting at, and it's probably been vague. So cost of healthcare goes up, provider costs going up, benefit going up, and you're saying there's a hole in the budget that we got to figure out, which is the reason we can't give SNAP a raise.
No,
what I'm suggesting is we know these costs are going to go up, and either in previous budgets they have been baked in and anticipated, or they have not. And if they were not baked in and we left a hole and we're saying, well, because of a hole that we should have anticipated, we're not going to give SNAP a raise and we're in this emergency, but I'm not sure that it's an emergency, and I'm not sure that this was unpredictable.
Well, we have, some of the best forecasters in the city and setting our budget. But it is a very volatile environment when you try to match government spending to government revenue, because you're asked to be Nostradamus. You have to figure out where that spending is going and where the revenue is going. And then you also have to be cognizant of what pressures develop in the programs that you budgeted at a certain level, but emergencies develop that push you over that. I'll give you a classic example. When, Laura has a certain budget for homeless services. I come to see Laura, I said, look, McPherson Square has become a problem. It is unsafe, it is unhealthy. If we shut that down, are you going to be able to put people in housing? And that's not in her budget, but she does it because she knows that's what the humane thing is to do.
How's that a comparable example to health benefits, which is something that happens every year, it increases every year?
Well,
Tenth encampments don't happen every year.
No, I'm not good enough to predict that McPherson Square would have occurred. I'm not.
Right, but what I'm saying is we knew that these health costs were going to increase. But now I'm hearing from the administration, there's a deficit or a hole in the budget that we can't cover. But these are things that have to be calculated. So it sounds like the calculation was way off.
No, you're not listening to me. There are two things that have propped up that have a value of over $800 million. The government is now in the phase of formulating the budget for 2025 and looking at what's projected to spend for 2024 to see if we are still on track to meet the promises that we made within a revenue structure that was identified. So we already know that there's an $800 million bubble in there that we have to account for in 24. Now, 25 is still being developed. So what
budget in 4 years though. So we budget in 4 years. So I'm not talking about fiscal year 25, I'm talking about fiscal year 24 and fiscal year 23.
Yeah, but you don't know what's going, you can budget in 4 years, but you don't know what's going to happen in those 4 years. That's not, no forecast. Who would have predicted, the pandemic?
But the pandemic and these tent encampments are not comparable to health costs.
But yeah, I'm not saying that the health costs that we have identified in 24 that we identified were unbudgeted.
Can you send to the joint committees what the projected cost increase were for provider costs and for Medicaid?
The mayor's budget submitted for 2024 was fully funded. Can
you submit to the committees the projected for fiscal year 24 and fiscal year 23, the projected provider cost increase and Medicaid increase?
I'm sorry, I don't understand the question.
Can you submit to the joint committees the projected increase in costs for provider costs and Medicaid for fiscal year 24 and fiscal year 23?
We can submit what was submitted to the budget, and it was funded. But then you have to get through those years.
I'm just asking to send that to us.
Well, I'm sending it, but I want to explain. We submitted, and it's funded. The mayor's budget is funded, and it's funded at 100%. Then you get into the actual operation of the year. Then the question becomes, did something happen during that year that you didn't capture in your forecast?
I just want to see the projected costs and the actual costs, and that's going to help us know whether this was a self-made crisis.
For 23 and 24?
Yes.
Sure, we can do that.
Thank you.
Well, actuals for 24 are, when would they be available? What month are we in? What year was this, 24? Oh, yeah, 24 is a moving target. We do our first quarter FRP in January.
The mayor's FY24 budget was submitted at the beginning of this calendar year.
Right, but I thought you asked for actuals.
Yeah, year to date for actuals.
Well, we do our first quarter FRP.
I want the projected as well.
We do our first quarter FRP in January, and we can tell you whether we are above, below, or right at what the mayor approved for us to spend.
Okay, projected and actual to date.
Yes, we do that in January.
Thank you, Chairman White. Councilmember Parker, it's your turn. Let me just say this, Director. It's always hard when you have colleagues because I want to pick up on some of this stuff. It's like, leave it out here. You just gave a new reason as to why you can't give SNAP a raise, which is spending pressure within healthcare finance, which we never talked about before.
No, I didn't say that as the reason. I was giving it as an example of what we have to go through in the 25 budget.
Okay. And I will also say this, because I want to give your team at healthcare finance some credit in terms of spending. Whatever you all did in FY23, you were able to manage it enough that you were able to send 10 million back to the general fund at the end.
That's right.
So there's some management of things happening. You guys told us at the beginning of the year, you thought that we would,
more than that.
10 to 20% of people would probably come off of Medicaid. Right now, we're at 19% termination. So I want to give credit to your staff in terms of who is doing calculations because they're getting it right. And I don't want to bring them in to sort of this piece. But I also think that telling Councilmember White that the mayor's FY24 budget is fully funded is also disingenuous, knowing that the TANF COLA was not fully funded when that budget came down to us.
My understanding of district government is if the council approves the mayor's budget, then it has to be fully funded based on projected costs and projected revenue. Now,
No, the CFO certified it, but the money was not there. And I know that's a back and forth, but we can get it.
I'm not gonna take issue with what the CFO did. I mean, he certified the budget as being fully funded. So what am I supposed to say? What am I, the CFO, Chief Financial Officer, the budget is.
Yeah, but you know the money wasn't there.
The CFO said the budget was fully funded. I am not gonna argue with him.
Okay. Councilmember Parker.
Thank you. I think part of the frustration that I'm hearing, Deputy Mayor, from you and your team is, look, we're at 80%, or at least May, June, September, we were at 80%. I think now in terms of re-enrollment, you're at 67%, if I got that average right.
If you look at the total from when we started in April to now, it's about 69%.
69%.
That is the total number of people who are enrolled, not pending.
Got you. And I remember the days I was a teacher, the magic number was 80%. Get 80% of your students to master the content and you can move on to the next standard. And it always kind of bothered me. And what I'm getting at here is, what about the other, what is that, 33% or 31% if we go with your number, that are not re-enrolled?
Well, two things.
And I know a portion of that number is pending.
Pending, that's a big number. So you're talking about 69 plus. If you go back to the chart on slide 16.
But let's say we know for those over 65 and those with disabilities, and even in your slide, you acknowledged that there is a significant fall off rate for those populations, that they are not re-enrolling. And there may be a number of reasons for that. We talked about one of them was the EPD waiver and those that have case managers not actually following through and renewing them. What is being done to reach residents over 65 and that may have disabilities that are most at risk of not renewing?
Yeah, Melissa's gonna give you that. But what I want to say on the numbers is you cannot overlook the fact that for almost 2.5 years, we didn't disenroll anybody. And caseloads hit a record high. It is likely 10 or 15 or 20% of those people are not eligible. And so those, through the recertification process, have to be identified. And those are the people who are showing up in terminations. So you have 69% of the population that is due for recertification already enrolled. Then you have a roughly 15% group that is pending.
Yep.
Many of those will probably be eligible.
And I'm coming to the pending.
And then you have a termination of about 19% at the end of November. And again, and
the lion's share of those terminations are, as I understand it, individuals over 65 and that have disabilities.
No, the lion's share of those are persons who are called magi. 77% of the, if you look at the non-passive renewals, go to slide.
Or put differently, residents 65 and over and with disabilities are losing coverage at the highest rate.
No, go to slide 20.
I guess the premise here, I'm pulling this up on my computer, but can you speak to what is being done for to reach out to those vulnerable populations to help
Sure.
ensure that they can maintain their coverage?
Yeah, Melissa and her team are leading that effort, and it is a robust one, and she can describe what's being done to do that.
Thank you. First, I would say your reaction as a teacher to the 80% and kind of don't worry about the 20%. I have the same reaction you do to that. And that's not, if I've somehow conveyed that we're okay at 80%, then that's not what I'm intending. We are looking at that 80% more and talking about that number in the sense of a lot of what we've heard today is that the system doesn't work and we need to do something about it. And when I see that we are looking more at that 80% renewal, that says to me we have some issues and we need to pinpoint them and resolve them, but not necessarily start wholesale over on a system. So we take very seriously the impact for any of those folks who don't renew and should be. So I just wanted to share that with you. When it gets specifically to I'm going to talk more about non-Magi, which does bring in that group of the 65 and over. There are two subgroups to that where we see the largest no response. The first group is what we call our QMB only. And with that, that's a group of folks who have Medicaid and Medicare. So they have Medicare coverage first as QMB only. Medicaid is only paying their co-pays and their premium payments for Medicare. We're not actually paying for any services, healthcare services they're receiving. We're paying for that cost sharing. So we're trying to figure out why we can't reach these folks either. My best guess at this point is they just don't have a relationship with us. Does that make sense? And then in the sense of like, we're not who they go to when they can't get into the doctor, they go to Medicare, right? What I've heard anecdotally is some concerns with the application because our renewal form is quite different than a Medicare renewal. We ask for a lot of information compared to Medicare. Medicare, you turn 65, you show up, you sign up, they know who you are, you pick out your plan. So we're trying to figure out how we can better reach folks to understand the importance of QMB and how we work folks through that application. The next subset that we see the high no response rates in our non-Magi group are folks who are what we call our age blinded disabled category at 100% or less of the federal poverty level. This is a group, again, we're trying to parse the data the best we can to really understand who these folks are, why aren't we reaching them, why aren't they renewing, so forth. So I don't have better information for you at this point, and we're trying to figure that out to figure out how do we better reach out to folks. We've done all the mail, the texting. We participated in ANC meeting that the chairwoman hosted for us. We're out at different health fairs, et cetera, or just citywide fairs and trying to work through the community to get the word out.
And I would offer partnering in Ward 5, and I would imagine my colleagues would be willing to partner as well on the ground. I think there needs to be more grassroots outreach. A question I had when I was looking at your numbers, surprisingly, we see Ward 7 and 8 actually at the highest levels of re-enrollment. I would imagine that's probably because they just have more people that are
total numbers. Percentage wise, it's pretty even across all the wards. But from a numbers, yes, you're definitely going to see more folks in 7 and 8 just because they comprise the larger share of the Medicaid population.
Got it. Okay.
I would as a helpful perspective, we cut this data 100 ways when we try to figure out what's going on with people who are not responding. And one thing we found is that when you look at, for example, the total number of people in 2021 who did not, whose earliest year of enrollment was 2021. That means it's the first time they touched the Medicaid system. 29% of those folks have not responded. And if you look at that as a proportion of the non-passive, it's 49%. Those are substantially higher than we see for other years. If you go down to 2020, which is the beginning of the pandemic, there were 8,653 people whose renewal was initiated. Of that number, 52% was a non-response for non-passive. So these are higher percentages than we see for people who enroll much earlier, suggesting to us that potentially a good portion of these folks are just not eligible. They're just not taking they're not taking the time to respond and tell us they're not eligible. They're just not responding to us. But we continue to dig, but I think that is a real number that has real consequences.
And the other thing I would say to that point is that 2/3 of the folks who haven't responded have not used a service in more than 12 months. So that's no prescription, no doctor visit, et cetera. So for me, that tells me, again, most likely they know they're not eligible.
Okay, two things I wanted to follow up on. We heard several of the testimony we heard. There were several instances where a patient was listed as inactive and then was later told they were active. More accurately, they were listed as active, but found out when they went to the provider that they were inactive. What is the course of action there outside of the case manager? As we know that there are natural breakdowns and quality ranges there, what can a person do if they are in that situation where they are finding out that their benefits are not listed as active?
Sure, there's a number of different things. You've heard the various call centers. We hold a biweekly stakeholder call that's welcome to anybody. We oftentimes have a number of residents.
At the provider in real time and they tell me, okay, you're not listed as active, is there not an urgent hotline or triage unit that I can call to say, hey, can you just confirm or flip a switch?
We do for the provider, yes. The provider can go to they have a portal and then they can check eligibility from that vantage point. That's the MMIS. So that should be current and should confirm the individual's status.
Okay. If you could follow up on just what that process should look like,
sure.
Because it would be helpful to equip people with that information, because what I heard was gut-wrenching testimony for people who are trying to get their children service and they're being told there's a barrier between them getting that service.
And depending on the provider, like if someone's showing up at an FQHC, that FQHC will help them with any issues at that point in time, typically to work through their coverage issues, and we'll still go ahead and see them. But yes, we'll follow up on that.
I am at time, but thank you all for your testimony. And Deputy Mayor, it seems like there may be a window to actually move gift snap arrays forward. That's not what you said, but that's what I'm interpreting. And so I will follow up with some just recommendations, but want to just thank you for sharing as well.
We welcome your recommendation.
Thank you, Councilmember Parker. I want to ask some specific Medicaid related questions. Ms. Karen Dale, who's the CEO of AmeriHealth Caritas, didn't testify in person today, but she did submit written testimony for the record. And she stated in her testimony that in September of 2023, newborn Medicaid IDs were pending for as much as 6 months, but that's now down to 90 days. What's the cause of these delays? Is this a ESA issue or is this a DCAS issue?
So what I would say is this is where we have policy clarification that needs to occur on here, is that based on the system rules, if a resident is up for renewal, then they must complete the renewal prior to adding the newborn on. And so we found an influx of children who were not able to be added to the case because they had a pending renewal.
Okay.
That has since, we are looking at that now, we are addressing them, and we have a process now where they are identified since September, I think about September time, they have been identified, and we are manually making sure that the children they have coverage moving forward.
So in that particular case, are you manually then pulling the parent's application to priority process them and then add the dependent?
No, what we're doing is just going ahead and kind of like doing the same back end extent of coverage for the newborn. We're just going ahead and putting the child's eligibility through to ensure they have coverage.
So is that going to cause problems when Director Zeilinger staff then gets that Medicaid renewal application? Now you have a child who is kind of dangling?
It shouldn't. It shouldn't.
Okay. How often are the teams talking to each other?
Daily. Daily, hourly. We meet quite often. We're in constant communication. Our processes are very much so intertwined. And so we understand the issues that are coming up. I mean, we definitely talk to each other a lot, and we meet about these issues and try and come up with solutions to a lot of problems.
Okay, so the newborn ID backlog is down to 90 days. That's still a lot. How often, if everything was working as it should, how long should it take for a newborn to get a Medicaid ID number?
As soon as we receive the information through our system, and and they're added onto the case. So as soon as we receive it, the system should be able to pick it up and basically add the deemed newborn to the case.
Okay, but how many days is that, like in theory?
I mean, so the processing is one thing. Once it's in the system, we can do that immediately. Once all the information enters the system and we have everything, that can happen immediately.
Okay. Is this a situation where parents may not know that they need to submit the information? It's like, I've seen this happen with DC Health, for instance. We'll get notifications from people. They're like, I didn't get my birth certificate. And it's like, well, yes, but did you submit the form at the hospital in order for the birth certificate to be processed by Vital Records? Or is this something else? Like, is it people not knowing and that's causing a delay, or?
No, because that happens directly from the case managers at the hospital.
Okay.
They input this information directly into the system.
Okay.
The system has the information, but if there's a renewal on the case, it sits there until the caseworker can touch it, because it has to wait for that renewal to take place. And so what we've done is we've identified anyone who's come over in that process with baby that's come over in that process, and we've gone ahead and started to manually determine the eligibility for them so they have coverage.
Okay, so it seems from the overall numbers that applications are coming in faster than the pending ones can be processed. If my calculations are right in terms of dates, thousands of more renewals were initiated on Friday, the start of December. So are we expecting the number to grow this month of the number of pending applications? You're not on the,
You have cited the one major concern that I have, with the caveat that we're making sure that pendants, are not missing coverage. But it's something we have to address. It has been growing every month since August. So I have no reason to expect that we've done something different, that we've been able to, change a process or a work input to reduce it. So what we have to do is, sit down and figure out, is this something that can be done from a systemic issue that can be addressed by some changes in the system, which is unlikely, or do we have to look at a caseworker workload again against the backdrop of people are pending, but they still have health insurance.
Okay.
So it is a concern, but it's not one that would be more concerning if people were not covered. I would be more worried.
Okay, but are we going to hit a point where CMS is like, yes, they're still covered, but you have too many applications?
CMS is going to focus on the new applications, and if we don't fix that, they'll say something. Again, when you look at where we are nationally, we're in the top 5%. I mean, we're in the top 5 states in terms of renewals, pendings, and terminations. We are in the top 5 states in terms of national data. So CMS is not likely to come to us and say, hey, you got a big problem here. They will come to us and say, you got to fix the timeliness of your new applications, without a doubt.
The one thing I would say is, if you recall at the beginning of the renewal process, we had to determine kind of how many folks we would go through the process per month. Those PHE folks, the folks that we had some indication already would not likely be eligible going forward. We really focus those individuals in their renewal time period between months 3 and 8, I believe. So in terms of total numbers, we won't have the same high numbers per month for the next few months. So we'll still have more folks coming in, but we've gotten through the majority of Medicaid renewals at this point in time.
Okay.
The other thing, and we'll continue to track too, like our December passive renewal rate for our Magi, I think is its highest, over 80%. And so again, that's something that helps reduce the caseload that might be coming into that requires caseworker attention as well.
Okay, in the DCAS system, do you all differentiate between a brand new app? I'm assuming you have to differentiate between a brand new application and a renewal application. Director Zeilinger, do you differentiate when you all are assigning cases to representatives, who's working on new versus who's working on renewals?
Yeah, they're in different queues.
Okay. So the numbers that we have in terms of pending application don't break out new versus renewal. At least, so on the dashboard that we have, that's only renewals.
That's correct.
I don't have insight how many new people are coming in.
We can give you those.
Okay, that would be helpful
Yeah.
to know, because while we're saying for those who are renewing, you're not going to lose coverage. If you got a new application, you got no coverage.
Well, not
So-
entirely true, because we will pay retroactive back to the date of application.
Sure,
Once
but
you approve.
if I went to go make a doctor's appointment and I didn't have any insurance that day, they're
No,
gonna
I'm just
give
saying,
me a
no,
bill.
No, you'll get a bill, but we'll pay it
How long?
back to the date of application.
No, I know, but in the meantime, I'm getting charged late fees.
Yeah, I mean, it's not an ideal circumstance, but all I'm saying is we do this when we have to, and we make sure that people that we pay for their out-of-pocket expenses on their bills.
I appreciate that we do the retro, but
Yeah.
I'm saying in terms of when we're thinking about, pending is able to continue coverage, renewals are certainly important, but
Oh,
the new
absolutely.
folks who are coming on, if I have nothing in the time.
We'll get you those data.
Okay,
Yeah.
so bringing up sort of the renewal turn on, turn off, though, I want to bring up something that Mr. Doyle talked about in his testimony in terms of individuals who are incarcerated and then they are released, having to submit proof of release in order for their Medicaid benefits to be turned back on.
Yeah, well, Tamika will fill in. No, one of the changes with the DCAS system coming online is that we have an overnight data feed between the Department of Corrections and the system. So we have now that automation of when someone's been released. So I'm not
When
sure.
did that start?
We've had that since we went live. We've had that since
November 2021.
Yes.
Okay.
If there's a discrepancy between what we receive from the Department of Corrections and what we have in our data feed, then those are the people who have to basically validate that they have been released. But
How do I validate that I've been released? Is that a piece of paper?
That's the operations process that.
Do I show up and say, hey?
That's I would have to turn to operations to see how they validate it, but our system can't verify the name, the address, the name, the date of birth, or this SSN, then we can't, turn it back on for them. But that doesn't happen. It's not a large number. We receive our nightly batch, and we go ahead, suspend that I code, and we basically they have coverage the next day.
Okay.
That's for someone who had coverage when they entered,
Yes.
became incarcerated.
Correct.
So we suspend. And that's one of the new opportunities too, that we are looking at with the 1115 waiver renewals, the ability to reach that 30, 60, 90 days prior to release. So that we can, right now, we're precluded from doing such a thing. And so that's something that we intend to explore as we go forward. The question that usually what I hear, the bigger concern from folks returning to the community is coming out of Bureau of Prisons. And that's a more challenging.
Because you don't
connection.
have
We don't have that
prior
connection with them.
knowledge.
Yeah.
Got it. Okay, thank you. Councilmember White.
Thank you. This is going to be my last round of questions. So and I want to walk through some technical issues that have been raised to me and my team, and let me start with the one we're discussing now. So if someone you're saying the majority of people released from DC jail have their benefits renewed automatically with them not having to do anything?
They are reinstated. So we're not allowed to, we have to legally suspend their coverage. If they have Medicaid coverage before they walk into jail, we suspend their coverage once they're incarcerated. And now once they are released, that's when we have the overnight feed and we update our system and we turn their eligibility back on, if you will.
Now, if they didn't have coverage before they went in, they'd have to apply when they came out.
Correct.
Okay.
To show support.
And so if it doesn't come back automatically, you said they have to submit proof of their social security number and some no?
No. I was saying that those are some of the issues that if we can't validate that, they will have to go ahead and verify that they are no longer there. But I would have to allow operations of probably DHS to speak to what they require them to use to verify. We don't.
Okay. What do they need to verify?
I don't know. I would have to check and find out.
We'll get
Okay.
that to you.
Thank you. Some of the other issues that have been raised with me and my team, some residents say they've been terminated from benefits due to their updated change of address not being recognized in the system. Is that something that you're familiar with?
I know one of the problems that I thought we had when the same person had multiple addresses in the system did not know which one was real.
Yes.
But I don't know how, if that's what you're referring to, or if it's, there are probably reasons the address wasn't recognized, and one of them, there may be multiple in the system, but Tamika could address that.
Yes, that's correct. So we know that we do have, as we've been talking about, sometimes a backlog of applications, recertifications. And so if this information is sitting in the system will need a caseworker to basically state which address should be selected, because it just has multiple addresses sitting there. So it requires a review to determine which is the most recent information and which one is accurate, so that then it will be updated.
Got it.
But a notice would have gone out to the individual, letting them know. But we need, when there's multiple on there, we require a person intervention to say which, basically what we call evidence, should be entered on there.
How many cases does a caseworker have?
So we've stopped doing, actually a number of years ago, where someone works with only one caseworker. So caseworkers pull a case, based on what queue they're working. And so if they're working Medicaid applications, they would pull the next one in the queue.
Okay.
On that day.
Got it.
So.
So how long would it take? So somebody has this address issue, a caseworker has to verify an address. How long before it reaches a caseworker, that case reaches a caseworker?
It varies, but I think we're seeing within 15 days that as things are incoming, unless they're depending on, so if it's an expedited SNAP application, that would be right away, because we have 7 days to process expedited SNAP, versus other change of circumstances, change of address, those types of things. I believe it's within 15 days that we would be touching that case.
Okay.
And that's going to vary based on workload trends.
Some residents have complained about receiving notices with inaccurate information in the mail. So in some cases, they say they'll get a notice that they will be terminated from benefits. Legal service providers believe these notices are being automatically generated in the system. Is that something you're familiar with?
Yes.
Okay.
Do you want to speak to?
I'd like to know how frequently it happens and how it happens.
So we would have to get back with you on how frequently, but I do believe it stems from an overlapping in processes of the system. We have basic rules, right? As to day 1, day 30, day 15, a notice needs to be sent out, particularly on renewals. We do it, notices goes out 90 days for non-magi, 60 days for magi. If we don't receive anything back within 30 days for magi, then we send out another notice. And in that notice, it says that if information is not provided, your case will be terminated. Now, when we have these extensions, have made it difficult because our notices are still automatically going out, but we are extending them in the background. So it's kind of conflicting information. And so we know that that's an issue. And we actually updated updated
November,
yeah. Yeah.
So we also, one of the reasons that would happen would be if there were duplicate cases, that people would get conflicting notices. There was a technical fix to this that went actually earlier in November that went into production.
So overall, we did discover that identified that this was happening. We were sending these notices. We met together, determined which instances this was happening in. And so we've made efforts to kind of make sure that it's not happening moving forward, but we can't, due to the fact that some of these factors are still ongoing, we can't say that it won't ever happen. But we do have, as Melissa said, if you are receiving, we ask people to call the call center so that we can validate what's going on or join any of our meetings to kind of ask about the notice or things like that so that we can make sure that we are giving the most accurate information.
How often do DHS and DHCF teams meet to go over issues?
So we meet daily to talk about issues. I know I meet daily with the administrator over at DHS for a lot of our issues that we have that are the joint issues that we're talking about. Our teams, we have at least probably 3 formal meetings a week where we go over the priorities, challenges, talk about solutions. So we have a number of touch bases to meet with the staff to, ensure that we are understanding their priorities and that DCAS is working on the right things at the right time.
One of my conclusions from this hearing is that there are some positive numbers and metrics that may be hiding from the view of leadership some of the issues that end users are having, possibly in particular vulnerable populations like children with disabilities or seniors. Do you all have a working group with diverse end users to get feedback from them on how they are experiencing the district direct?
For Medicaid, we do the Melissa, as she spoke about earlier, hosts the public meetings that happen bi-weekly. And that is for the public. Anyone can join, can express their concern. I know that DHS has a monthly stakeholder call where we also join into that call to hear any issues directly about District Direct. So we make ourselves available for any meeting that is happening to capture any issues that are coming up about District Direct so that we may address them.
I prefer to see a working group so that we can, on an ongoing basis, work through some of these issues, at least for a time. If there were to be a quarterly meeting, we certainly could host it, or you all could host it and we could join. Do you have a preference?
I don't think that we need you to host a working group. We will figure out a way to make sure that we're including all of our different stakeholders, either in the venues that we've set up to hear from people and make sure. But I think I'd like to kind of go back to the assumption, which is we're not aware of the problems, because we are aware actually. And I don't think we heard things today that shocked us, because not only does Deputy Mayor Turnage get calls to his cell phone, I get calls to mine as well. And we also have official escalation paths that people take advantage of. And when a staff member is working on a case and they have an issue, there's a process by which they reach out to a supervisor. If they're not able to resolve it, they put in a ticket with DCAS. It's called a CSL that we meet with. That's the sort of the behind the scenes data to capture the different types of issues that are emerging, that then it is Tamika described. They're looking at the patterns in those to determine what needs to happen around these particular issues. Is it the way that the eligibility worker is using the system and we need to train them while we work on improving the usability of the system? Is it a defect in the system where it's not operating properly? And then they work on a prioritization and reprioritization based on issues that they're seeing. So while we always want people to be seen and heard and have a forum for that, I just want to make sure that the problem that we're trying to solve, which is where there are people who are having issues that we're not aware of, that I would just say that we are aware. We do feel urgency around it. And we are, despite, I think, some of the assumptions, we are actually working very urgently, long and hard to address those issues.
Okay, I'm trying not to make assumptions here, but I'm listening to members of the public who testified, and I'm listening to the administration, and the two are not on the same page.
Because both are true, actually. Like, both are true. There are serious issues and there are things going well. And you're going to hear always about what is not going well. You're not going to hear about the thousands of people that seamlessly their benefits were processed or automatically renewed and everything worked great. We're going to hear about the people for whom they had a problem, because there's a reason why these are entitlement programs, and it's a crisis every single time. So I think we're focused on the problems and what we need to do to fix them. And there are a lot of areas where it's working well.
I would be surprised if any member who is or was on the dais or any member of the public could say at the end of this hearing, they understand what the path to correction is for the issues that were raised today. So we will convene a quarterly meeting and ask that you be there. We will invite some residents, and this is something that I hope won't be ongoing for a long time, but to help make sure we're not just having a hearing and then come back 2 years later for a similar hearing. And I want to make sure we're working in the interim. So if you all are working to correct these problems, then these meetings should not be an issue at all. Not going to waste my time, and I'm not going to waste yours. So they will be efficient.
It might be more efficacious if we sent you a list of the issues that we are working on. And then if there are issues that are outstanding that were mentioned today that we didn't capture in that list, then we can be informed. But we can easily generate a list of the issues that we have and that we have fixed, and the ones that we are continuing to work on that address a lot of the concerns that were at least from what I could hear from the testimony this morning. But to me, that would be more efficient. But we will. So we're more than willing to get you that list of things.
I appreciate it. If you want to send a list, I will take it. In the interim, we are going to move forward with quarterly meetings. Thank you, Chairperson Henderson. Thank you to our agency witnesses, and thank you very much to our public witnesses.
Thank you, Chair White. I just have a few more questions, and then we can wrap up. So we know that there have been, as mentioned earlier today, that DHS had to submit a corrective action plan to USDA FNS. My understanding is that the first plan was rejected from FNS in September, because they said that many of the proposed solutions would not be implemented until the end of FY24, and that some of DHS's proposed updates in the plan are for December of 2024. Why do these fixes take so long to implement? Is it money? Is it people? Is it policy complexities? All of the above?
Yeah, I would say it's all of the above. I think, we have a pretty clear roadmap around what's in the system and what the prioritization is and what we can do with the resources we have responsibly. And there is very robust testing every time there's new deployments to fix particular things from a systems perspective. And every time I think we could go through each thing as to what, how long it takes. But I think what you're missing is also that we do have a cap that's been accepted. We have several items that we've closed. There are items that we're still working on, and we're working on them with urgency. And our prioritization around certain things, which are really about making sure that people have the benefits that they need, are not always the same order of prioritization that we may see coming out of the federal government from a compliance perspective. And we always have to manage those tensions.
Okay. One of the issues that has been raised in the past was an overissuing of benefits. So USDA noted that over the last 5 years, since a major system failure in 2017, DHS has overissued benefits to a significant number of households, which is specifically attributed to defects in the DCAS system. And I think some of it might be the duplication of people in the system submitting multiple applications. How do we remediate some of these major types of failures? I mean, is there a communication to, so like, for instance, if I go to a website to say, sign up for, I don't know, Sweet Green, account. If I put in my email address to sign up for an account, it would say, you already have an account with us. Did you forget your password? And then it bumps you out. Does the DCAS system have that same thing if somebody goes in to try to submit another application?
We're actually not allowed to do that per policy. You are not allowed, if I already have in benefits and I apply for the same benefits, we have to allow it to go through per policy.
Federal policy.
Mhm.
Okay. That seems like a recipe for disaster.
I know that.
We actually.
'Cause that's wasting your people time.
I agree, but it is a federal policy we must adhere to.
Okay.
So,
Okay.
I mean, but there was a fix that went live in November to address the dual payment issue.
Okay.
So that was a code fix to correct a system validation functionality that prevents a caseworker from authorizing beneficiaries to somebody who has another case in the system.
Okay.
So there are protections on the back end, but it's not on the front end.
Not on the front end.
So it
Okay.
doesn't fix the workload issue, but it will fix the duplicate payment issue.
Okay. What happens when there is an overpayment?
It gets referred to and then we have a process by which we would work with the resident to collect that.
Oh, we go get it back.
Sometimes. And so there have been.
Sometimes if it's been spent and I'm like, I already bought.
It's actually not about whether it's been spent. It's about changing federal authority in this space. But there is a process by which, even if it's by paying less in the future over a course of months, that we recoup that. But
Okay.
it requires an authorization first from the federal government that before that happens.
All right. Do we owe the feds money for overpayments?
We have some funds in escrow for where we may or potentially owe them. So no, we don't owe money at this point, but we have reports of when that's happened much more frequently, very early on when we went live with cash and food.
Okay.
But we haven't had to pay that back yet.
But we have like a risk management fund in escrow, you say, if
we have at certain points, we have reclaimed fund. We do not owe the federal government money at this time, but we are prepared should we owe them.
Okay. We heard from we heard from a constituent about extreme delays due to application transmission issues with MBI as a contractor. Is MBI a contractor?
No.
Yes.
They're not a contractor with us.
I mean, they're a provider, but not.
They're provided with
Okay.
DBH.
That was the confusion I had too. I was like, is MBI the same MBI that I know of MBI? Okay. 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 Director Zeilinger, I just want to get this on the record. We and I have talked about this on when we had a pre-conversation to the conversation in a briefing around what is a case. The committee had asked DHS how many applications get processed in a day. And the response we got back was in the definition of in the form of a case action. Can you explain for the record what is a case action?
Every time that we I'm trying not to use the word in the definition, have something that we have to do with a case, it is a case action. So if a household is enrolled in multiple benefit programs or has a change of address and is due for a renewal, those are separate case actions on a case.
Okay. So you all said in a response to the committee that the current average is 5.5 case actions per SSR per day.
So Right. And so that's that average is a very crude number because it does not within that take into account the nuance of how long it takes to do a new TANF application versus a recertification. So which is why I spoke earlier to how long each of those transactions take, because it varies widely. And there's one on average that is around 80 minutes if everything is in the file, where others are 24 minutes. And you may have a household that has numerous children and people who have various family relationships, all of which need to be captured in a very complex way within the system. And it just takes a lot of time.
Okay. Can you help me walk through that? Because, well, let me back up. Are the majority of applications that we receive right now via online?
Yes.
For Medicaid too?
Oh, yeah.
Yes, I think so. Yes, yes.
Okay. So when someone is reviewing the application, they're not doing data entry. They're not putting items into the system. So I'm just trying to understand why it would take 75 to 80 minutes to review a new application. What are we looking for? Is it, I have to review every document that was submitted to make sure that it's real? Or is it something else?
So there are a range of things that a worker's looking at, and I would offer to council member that might be helpful to invite you to sit with us to see what is entailed on the back end.
I would love
because
to.
I'm probably not going to speak to all of the nuances of it, but if each program has its own set of questions that we're required to ask, and all of it needs to match up. There are a range of things that caseworker needs to go through and document and verify. That if there's any missing information, they need to try to obtain that information. And it's not just receive it, verify these 3 sources and hit approve. It's actually fairly cumbersome.
Okay.
It's also, we are doing a lot of work on our, to look at ways to reduce the amount of time it takes and automate more of the functions that caseworkers need to do manually. But unfortunately, it's not just a read screen and look up evidences and hit yes.
For your staff who might have been doing eligibility determinations pre the move to district direct, would they say that this system, their work in this system is different than when they had to do everything manual?
I think they would definitely say their work is different, but I would say that the system doesn't remove all of the complexity that's inherent in benefits processing.
And I guess that's where the rub is, because we spent $600 million on a system. And besides not having to maybe do the data entry for most of the applications that are coming in, it seems as though nothing.
And if it's a paper application, they're still doing the data entry.
Right. But if it's online, what has been the biggest change for a processor, I guess is my question.
I would say that if an application is fully complete, it is a much more streamlined process, but it's rare that it's fully complete with everything that's needed without contact that needs to be made with the household.
Should then we change the system whereas someone cannot hit submit until all relevant documentation?
That would not be, that's not allowed in the federal rules.
So if all I have is a name and address and an SSN number, you got to accept it even though I didn't provide anything else?
Yes, and your benefits are going to be prorated back to the date that you hit that first application, but you might show up in our pending number for a long time until we get all of what is required to verify, to complete your eligibility.
This is one of these
and
situations.
This is one of those areas that's going to, that hits our timeliness number because it doesn't distinguish necessarily around whether it's a
completed application or not.
Right.
Yeah.
So
matter.
your timeliness number is calculated based on whenever something was submitted, not if it was a complete application submitted.
Yes.
Which is a flaw in my judgment.
Okay. But we also have the same rules as every other state and they've figured this out. So is it our people just being like, ooh, I want to get my benefits starting January 1. I don't have my documentation. So let me just go ahead and.
Our timeliness, you might also notice, shifted when we started having multiple ways that people could apply. So the fact that you can go in and apply, we think is great and makes the program more accessible. It also has impacted our timeliness.
But when you went in to apply, that also limited the number of people who can apply in a day, right? Because if you had to sit with someone, someone,
You could
I can
drop,
only
I mean, you
do,
could drop something off. You had people lining up. I'm not saying it was better. It wasn't.
yeah.
I'm just letting you know that we have people coming in through multiple entry points 24/7, as opposed to when we're open for business in the day and who makes it there that day. And sometimes people are putting information in multiple ways, and we need to be able to bundle those into one case.
Okay.
And that is also a step right now to search for all of the places where somebody may have
Submitted multiple applications.
Yes.
Does that, so the DCAS system does not automatically flag duplicates?
A worker searches. Is that correct, Tamika? They search. Yes.
So someone has to actively search.
Yes. What you're asking, sorry, is if I submitted multiple applications?
Yeah, let's say I submitted online, I didn't hear anything back. So I'm gonna now take my physical application down to the service center. Does the system, like, could you run a report to say we have
Yes,
X number of people who are duplicative?
Yes,
in the
we
system?
can. We identify that, and it can, I believe we actually do have reports that are sent or made available to identify that.
Okay, can we get that number? How many duplicates are in the system? And what happens? Is there a team of people who deal specifically with duplications?
How many I just want to, because duplicates is one of our terms that means many things.
How many duplicate applicants? What do we call them?
Applications, like say, like Medicaid.
One person, many applications.
Yeah.
For the same program.
For the same program.
Right, because obviously there could be somebody they have a TANF application at the same time they have a Medicaid application. I'm not referring to those people. I'm talking about the person who has 2 TANF applications and 3 Medicaid applications in your system.
Mm-hmm. Yep.
Because I feel like deduping gives us a more accurate, or at least I know you can't necessarily do that in terms of the reporting out to the federal government, but for us, it gives a more accurate number of what we're actually talking about here.
Yes.
In terms of how many people, but also it would seem that there could be, I don't know, a team at one of the agencies who's just dealing with the duplicates. Why did you submit 3 applications for the same program?
I absolutely appreciate you solutioning with us.
Okay.
And I'll ask you to understand that we're very focused on this issue and working on it intently with the DCAS team. It comes up in many ways. So you might have an application, but you may submit your evidence over here and then again over here because you got a notice in the mail that was generated before you put it in the mobile app that we still need a certain verification. So then you came and you submitted again. So which is why the definition of duplicate is complex because which is also why it's really important that an eligibility worker at the time they're processing a case does a search to identify all of the different incoming tasks or case actions that are in the queue for that household and bundles them together. So because they are interrelated. It wouldn't necessarily work for us to only have one team that is focused on that, but it's actually become part of what a worker has to do in their processing.
That's fair. I just say this, I can't just sit here and look at these numbers and not offer solutions because constituents are coming to us saying what's going on here. And they don't have the data and information that we have and, all of the various reports and corrective action plans, et cetera. What they see is I went into I submitted my application in August. I log in today. It still says I'm pending. My grandchild doesn't have insurance. That's what they see. They don't see the conversations. And so that is why these oversight hearings are important to illuminate the work. I don't doubt that you all are doing something, but I also see the numbers not moving. And so then I have to ask the question, what additional supports or resources can perhaps we provide to help you all do your jobs? I'm not trying to do your job because I don't know. I didn't go through the 6-month training to do an eligibility application. So I'm trying to better understand why it might take all day to do one application. That's
It doesn't take one day to do one application. I'm
not saying
but it is more than an hour. It is more than an hour-long process. And at that point, it may not even be complete if not all the information is there and there's more follow-up needed. So it is a long process. But I think what maybe I have not done adequately in this hearing is tell you all the things that we are doing in order to solve this problem. I mean, there are numerous things listed at a very granular level that I know you have access to in terms of what's in our cap.
Yep.
But I will just like aggregate. Okay. So one is, it's really important that people have access, and they have multiple ways they can both submit applications as well as to give the information. So we have more than 200,000 residents using District Direct, and we have more than 4,000 daily active users on the app who are putting things in. So there are some things about that are working, and there are ways that we can continue to improve functionality there that is going to have a positive impact on the customer experience. ESA is providing services every single day to more than 850 residents. We have hired new staff, as we've talked about. We hired a total of 136 case processing staff. We are training them, retraining them. We have added to our call center, central processing, and other specialized units. And we are bringing on a contract to move so we can move more of our eligibility staff from call center to case processing. And while they do need additional retrainings, they haven't been processing cases for a while. That is going to have, I think, a very significant impact on our productivity. We did a SNAP accuracy and timeliness conference with our eligibility staff to generate a lot of ideas from the people who are in the work every day and come up with a whole set of actions that we can do to improve and to support our staff to do the work that they came to DHS to do, which is not to pend applications, but to make sure that they're serving, and we're doing that. We have added additional technologies like Amazon Web Services that we are using just for call center to feed more aspects of case processing. So we have better ways to coach and train and identify where we can support staff and track productivity. We have added customer ambassadors to our service centers to greet people as they're coming in, understand why they're there, and to help direct them so that we can serve them better. We also, if somebody wants to sit down at a computer terminal in one of our service centers, we have staff who will sit with them and help them through the process, so that if there are any issues with understanding the questions, literacy, or just getting through, and that also allows us to learn what is challenging. And those are the things that we share with the DCAS team when we meet with them around our business processes. We've moved to mailing EBT cards so people don't have to come in and pick them up. We have a number of activities around our business process redesign. I mentioned that we're moving back to one and done or one touch from people dropping things off, which had been our practice throughout the pandemic, and we were hesitant to return to because we don't want to see long lines outside our service centers. But we do think we did see greater efficiencies and less repeat touches to the agency and returns when we were able to process something end to end with someone sitting in front of us. We have applied for and received a number of waivers to help us, including the call center waiver, which we're very excited about implementing. We also have a waiver for elderly simplified application for benefits, which extends the research period for people over the age of 60, I believe, who are on a fixed income, so that their eligibility period is extended to 36 months. And then that reduces helps ensure continuity of their benefits, and also reduces the number of times that they need to come in. We have advocate engagement. We have various venues that we are actually soliciting customer feedback and doing data testing as well. We are also looking at a number of AI and modern technologies for reducing repetitive rote work, enhancing process mapping, having co-pilots on the screen to help people with complex cases so they're not having to stop and call for help. These aren't things that we have yet, but things that we're exploring that we think we've seen make a big difference in other states. We have $1 million grant for a digital mail room. A lot of people, we have a ton of return mail.
Can I
because
ask
people
this, Director Zeilinger? I appreciate you going through this list. Do you have associated goals for the timeline? So
yes.
By February of 24, this is what we would like. This is where we would like to
Yeah,
be.
so we have numericals in terms of improving our case processing
Okay.
that are part of our corrective action plan. It's 1%, which sounds like a small percentage, but it's actually a large volume of people per month. So it's a 6% over 6 month improvement in our timeliness.
Okay, so the corrective action plan, correct me if I'm wrong, is only related to FNS related programs.
SNAP, yes.
It's not related to Medicaid.
No, it's a whole different set of it's right. It's not related to Medicaid,
Okay.
but I think we've established a lot of things that we're doing in the Medicaid space.
Correct. So Director Turnage, is there a goal of what you want to see in terms of the number of Medicaid applications that are pending come February?
I have not thought about the reduction in pending cases in terms of a numerical benchmark. It's something I would have to sit down and look at some more variables to figure out what would recommend, what would represent progress and what is doable. So
Okay, do you mind putting some thought to that?
no, absolutely.
Because I think that helps if we know, are we just riding a wave or are we seeing some significant movement in terms of our numbers?
No, that's fair.
And it could be a situation similarly with the Office of Human Rights, had a very, very long case backload, but they had some cases that had been pending for over 1,000 days. So it was goals around, all right, we're going to reduce this 1,000 days down to X. I don't ever anticipate us getting to 0 pending, but I feel like 18,000 is a lot. It gives me a little bit of heartburn knowing that you're going to have more this month. I don't know, you say they haven't lost coverage, X, Y, or Z, but at some point we're gonna have to go through those
I
applications.
think the way to target is to focus on cases over a certain number of days.
Yes, so if we could do that.
Pendants will always be there, as you state. The minute somebody submits something that doesn't, it's not a complete application, then it's going to be pending.
So maybe it's starting with the cases that are currently pending over 90 days.
Yeah, we'll take a look at it.
Okay.
Even though we're top 5 in the country, we'll take a look.
Let's be number 1, Wayne.
Absolutely.
All right. Let's be number 1 and on the list. Okay. We had a lot. I think we covered a lot today. I think it would be helpful to see some updates on some things that we talked about. The number of duplications. I would love to know the list of new applications. I'm just going to go through my list. Okay. So Councilmember White asked for the projected increase in costs for the provider costs for Medicaid for FY23 and 24, projection, actual, and year to date. We would love to know the number of cases that are currently pending with the Office of Administrative Hearings by program type. So SNAP, TANF, Medicaid. Duplicates, which what we talked about, and what happens to them in the system. And then a plan with benchmarks for processing. So 90 days, 60 days, 45 days, this is what our goals are gonna be for the remainder of FY24.
Okay.
Let me just check. Okay. Director, you mentioned that you're currently in the process for the FY25 budget, and I recognize that there are pressures, but I hope you guys, this is like advance foreshadow warning type. I would hope that there will not be any reductions in the budget for the Department of Human Services, given the case numbers that we're currently facing. To the extent that you could advocate for that on behalf of your cluster, that just, in my opinion, would not be a recognition of the reality of what is currently being faced. I know vacancy savings is often an easy way for people to recoup funding, but I don't, if you all are telling me that it's not system, not all of it, all of our issues are system related, then there are some people pieces here too that we got to work on as well. And it can't just be the same if we don't make, I think as Director Zeilinger said, we had a 400% increases in the tasks to process a day with only 17% more people. That has stuck out to me from this hearing. And so we got to figure out a way to sort of rectify that going forward.
Not necessarily a one-to-one correlation. In other words, you have 400% increase in caseload. That doesn't mean necessarily you have to see a 400% increase in your people.
Oh no,
Okay.
I'm certainly not suggesting that she needs a 400% increase in people. But I also didn't even get into like a social, the SSR. I don't know how much they make, but I'm sure the jobs, it's taxing. You're dealing with people. Yeah. You're dealing with people who are very frustrated in that time because, as you said, Director, it's for many of them, it's at a time of crisis, right? I need to feed my family. And I do not have any more money. And you're telling me it's a computer code problem that can't be resolved for 60 days, right? What are my options and sort of what am I going through? I think of it in a very, so all of our customer service facing jobs are difficult, are tough. 911, difficult, tough. I don't think they make enough money. The DMV folks, right? Difficult, tough jobs. And so I have to imagine from the perspective of a worker, when you're like, I'm doing all I can, I'm getting this income coming in, and I'm telling you that I need more support to take the load. And then they're not seeing that. They're like, well, let me go someplace else. I think the difference between the human services and say DMV is that, at least for DMV, I don't know the last time you got your driver's license updated, but when you go, before you even walk into their waiting room, there's a person who's standing there who looks to see, do you have all the documentation that you need to complete whatever the transaction is? And if you don't, they turn you away before you even walk inside. I'm hearing from you guys, you can't turn people away, even if they don't have the documentation. So like, it's the frustrations are even amounted more. Nonetheless, I appreciate all the public witnesses who testified today. I appreciate the government witnesses for being here, for the information that you all provided to the committee. There will be ongoing oversight on this. Like I said, this is our third hearing on Medicaid. We'll keep it going. I anticipate the next conversation we'll have about this will be during performance oversight in January or February. I don't even know what the date is, but that's the window. And I hope that we can see some progress by then. I know it's only a couple of weeks, but even still. So this concludes our oversight roundtable for DCAS and the Health and Human Services Benefits Enrollment System. I want to thank everyone again who offered testimony today. For those who weren't able to testify, the record for this hearing closes in 2 weeks. You could just go to the council's hearing management system and upload your testimony right there. So the record will close Monday, December 18th at 5 o'clock. That is all that I have for right now. Thank you again so much for your time, and this hearing is adjourned.